Hello everyone, can you guys see me? Is the audio clear? Is the video input clear? Hi, good evening. Good evening to one and all. So while we wait for another couple of minutes before we start, why waste time? Hi, Dr. Med, Himanshu, Manoj sir. Before we start, just a quick question to you guys. Hi, Vanessa. Can you guys guess which are the drugs that can cause pleural effusion using this mnemonic? So, in this mnemonic or a picmonic, there's this lady. We just had Eid yesterday, no? So Eid Mubarak to everybody. There's this lady who is telling her son Danish to go bring some methi so I can cook the night's meal. And then the son, being a good son, is saying, okay, Ami, me and brother or bro will go bring it. So there are 5 drugs which can cause pleural effusion based on the words which are highlighted, or the letters or alphabets which are highlighted in red. Can you guys in the chat box guess or name the drugs which can cause pleural effusion? We'll start in just a couple of minutes, ensuring that everybody is getting the audio and video clearly. Any clues? Drugs which can cause pleural effusion. Good evening to all of you who have joined online. Thank you very much. Nawaz, yes, nitrofurantoin, very good. So the night's meal, night stands for nitrofurantoin. Nitrofurantoin does lead to pleural effusion. It will be eosinophilic effusion. Ami stands for amiodarone, very good. Amiodarone, notorious, so many side effects, amiodarone, including in the lung and in the pleura. Pleural effusion. In the lung, it will lead to idiopathic pulmonary, or rather it will lead to interstitial lung disease. Very good. Any others? Very good, Saurabh. Very, very good. Dan stands for dantrolene. Methi. Okay, methotrexate. Good attempt. Methotrexate is more towards causing interstitial lung disease rather than pleural. So it's methi, not metho. So something that the name contains methi. Bro is bromocriptine. Bromocriptine, very good, Saurabh. Bromocriptine, it's used in treatment of prolactinomas, or basically as a dopamine agonist in prolactinomas. It can be used in treatment of even Parkinson's disease. Methi, okay, it's methimazole. Good attempt. Methimazole is a drug of choice for Graves' disease, antithyroid drug, TPO antagonist. Amiodarone, very good. Bromocriptine, absolutely correct, dopamine agonist. Okay, methotrexate, as you guys were trying to say, methotrexate produces interstitial lung disease. So any patient with rheumatoid arthritis, when you're treating them with methotrexate and they develop interstitial lung disease, you're worried or you're confused whether it's the rheumatoid arthritis disease activity that produced the interstitial lung disease, or whether it's the methotrexate that you were treating them with that has produced the interstitial lung disease. The difference would be, in rheumatoid arthritis, generally the interstitial lung disease is of usual interstitial pneumonia type, UIP pattern, whereas with methotrexate it is NSIP, non-specific interstitial pneumonia pattern. So that difference helps. But yes, very good. Methisargide, Dr. Med, Prashant, very good. Methisargide. So you guys, all of you got all the drugs right. Okay, Shashank, nice joke. Right. So welcome to everybody. I am grateful that you guys have taken time out and joined for this session where we try and discuss the important topics in the build-up towards the May INICET. So without wasting any further time, I know there are other better things live going on right now to watch than to be listening to me, but I'm grateful that you guys have joined. I don't want to waste any of your time, so getting on with it. So today's session is going to be yet another in the series of prepathons by Manipal Medes. So this is for INICET 2024 paper leak. No, I'm just joking. No paper leak here. Okay, we are only trying to build your confidence and get you to perform better. You've been joining us from 1st of April. Starting with anatomy from Tejasvi sir, and then the latest session yesterday was taken by Nishant sir in surgery, and it was a very good session. So please continue joining us for these sessions where we try our best to try and prepare you for the upcoming INI exams. Okay, so getting on with the discussion, I'll start with cardiology. We have a long way to go. It's medicine, so that's why it'll take a long time for me. I'll try and do it as early as I can. Okay, and try to keep it as relevant to your INI exams as possible also, and we'll try to keep it interesting also. Okay, discussions and inputs from your side are always welcome. Right, so starting off with cardiology, you guys know that ECG related questions are a favorite. So anyone who sets the INI paper, they're really one of the few chapters which they really prefer taking questions out of is ECG. So ECG based questions are something that you need to expect, apart from other clinical cardiology questions also. So mitral stenosis based and murmur based questions are very frequently asked in INI. So these are some things, if you're preparing for INI, which is next month, you need to be aware of ECG and clinical cardiology based questions. Apart from that, heart failure and acute coronary syndrome based questions are also frequently asked. Last couple of years, they've been asking about NSTEMI, okay, heart failure, the drugs related, and hypertension based questions. Okay, these are just some of the topics which, based on the question papers, the last few question papers, number of topics from which questions have been frequently asked, which I've highlighted here. So we'll start off with ECG. So I hope you guys have got an exposure to ECG during your undergraduate days, or you've been able to go to the ward and see and learn a little bit about the ECGs, but you will be tested based on these. So as recently as November INI, where there was a question, okay, based on ECG, and they had given this kind of an ECG. So reading the scenario, we'll start off by reading the scenario. It's a 14-year-old boy was brought to the emergency room at 5 a.m. in the morning after his father noticed that he had developed an agonal breathing in sleep. So based on this clinical history as well as the ECG finding, what do you think would be the diagnosis? What you can notice straight away is in the precordial leads, that's the V1, V2 and V3, you can notice that there is almost like an RSR dash pattern, right? So it looks like a right bundle branch block, but it's not. It's not exactly a right bundle branch block. What is it? There is a coving, okay? So coving of ST, coving ST elevation. So whenever there's an ST elevation, you're worried whether it could be a myocardial infarction. But this kind of convexity upwards, this kind of a convexity upwards is almost hyperconvex, right? So when we expect in myocardial infarction, there is going to be, okay, Meenakshi is asking if I'm bringing Ram and Shyam. Okay, so when there is an MI, then when there is a myocardial infarction, you do expect a convexity upwards type of ST elevation, and that really helps you to distinguish this kind of ST elevation from pericarditis ST elevation. So in pericarditis ST elevation, you expect it to be a concavity upwards, right? And there'll be a little bit of PR depression also. So PR depression along with the concavity upward ST elevation points more towards pericarditis, right? Whereas in ST elevation MI, STEMI, you expect there is an ST elevation with a convexity upwards, but not so convex also. This is quite hyperconvex, okay? So it's not an RBBB, certainly not, because the ST is definitely elevated. In a right bundle branch block also, you may get this kind of an RSR dash pattern, but this is not. This is instead ST elevation with coving upward pattern, and this is what you see in Brugada syndrome. Very good. Many of you have got it right. It is Brugada syndrome. So among the options, Brugada syndrome would be the right choice. And this is aided by the clinical history. So it was a young boy who's developed agonal breathing in sleep. So whenever such events happen during sleep, so a patient ends up collapsing during sleep or during fever episodes. So fever and sleep would be important history for Brugada syndrome, because these can end up triggering malignant arrhythmias, and that is why the patient or the boy ended up developing agonal breathing. Okay, so likewise, if the scenario was different, if they had instead said that the person was an athlete collapsed while doing intense training, heavy intensity training, and instead of an ECG they ended up showing an image of the heart, maybe on an echo, maybe it showed something called systolic anterior motion. Maybe they point out, maybe they label the echo image or photograph with systolic anterior motion or asymmetric septal hypertrophy. What would the diagnosis be then? That is yet another examiner's favorite in INI, and not just INI, even in NEET. That is HCM. Very good. HCM or HOCM, very frequently asked question, and in that, instead of an ECG, no typical ECG findings, but you will rather expect that it will be an athlete, a young person who was trying to work out, and during heavy intensity training they ended up developing this kind of malignant arrhythmia. Okay, so the most common cause of death in HOCM is a malignant arrhythmia, and that has been also asked as a PYQ in INI. Okay, so remember the important points regarding HOCM. HOCM is, of course, like Brugada syndrome, both are autosomal dominant, inherited. Okay, whereas in Brugada the problem lies with SCN, sodium channel SCN5A, correct? SCN5A mutation for Brugada syndrome, whereas for HOCM the more common genes are myosin heavy chain, so MYH7 and MYBPC3. So, but both are autosomal dominant. Inheritance, you may get a family history even in the scenario where there has been a sudden cardiac death in a family member. Along with that, ECG change is very important for Brugada, whereas for in the case of hypertrophic cardiomyopathy, it will rather be echo, or maybe they've even shown an autopsy figure of or autopsy image of HCM heart, so they could even pose that as the clue. Okay, one final ECG change. So if a patient ends up collapsing and they're brought, and luckily they've spontaneously been resuscitated, and then you see in the ECG there is a coving upward pattern like this, then you definitely, in the precordial leads, you think of Brugada syndrome. If instead it was an athlete who collapsed and the ECG ended up showing something like this, okay, something like an RSR dash, but not quite like this. Okay, this is something known as epsilon wave. So where do you get epsilon wave? So they gave you a scenario where the patient is collapsed and they've shown you the ECG. In that ECG, after an R and an S wave, the positive and the negative deflection in the precordial leads only, it will be in the precordial leads, there will be a small positive deflection like this following the QRS complex, and that's called an epsilon wave. So epsilon wave is seen in, anybody? It's seen in arrhythmogenic right ventricular dysplasia. Very good, Saurabh. Arrhythmogenic right ventricular dysplasia. So similarly, it actually happens quite frequently where athletes collapse. They sometimes successfully resuscitated, sometimes unfortunately not. So, but when they undergo testing, it ends up being revealed on an MRI or perhaps on an autopsy that they had arrhythmogenic right ventricular dysplasia. So remember, epsilon wave is for arrhythmogenic right ventricular dysplasia. What about delta waves? Where do you get delta waves? Everybody knows this. So delta waves, delta waves are seen in other important points include bundle of Kent. I'll wait for the answer. Bundle of Kent, delta waves, PR being short. Okay, and the bundle of Kent is generally left lateral. Very good. WPW. Okay, so WPW, Wolff-Parkinson-White syndrome. This is yet another example of a cause that can end up producing cardiac arrest or malignant arrhythmia like a ventricular arrhythmia, ventricular fibrillation, where the patient may end up developing sudden collapse. Okay, so all these are possible scenarios which can be mentioned, which can end up producing malignant arrhythmias and a collapse. So keep these in mind, keep the scenarios in mind, keep the ECG changes in mind. This is how you may be tested. Okay, so Brugada, WPW, and epsilon wave of arrhythmogenic right ventricular dysplasia, and HOCM, of course. Okay, so this just highlights that you need to be able to recognize ECGs also. Sometimes if they give the scenario, it will help, but if they've given only an ECG, should be in a position to be able to diagnose, because they will give you questions based on ECG and related topics. Okay, so what I want you to do is, any ECG that is given to you, if you're thinking it's an arrhythmia, if it's a rhythm related disorder, first look at the rate. Okay, is there tachycardia or not? If there is tachycardia, then you can proceed differently. How do you find out what the rate is? So you guys should know the rate calculation on an ECG is you divide 300 divided by number of large squares between successive RRs, okay, for a regular rhythm. So when the rhythm is regular, between two QRS complexes, count the number of large boxes, and that will give you the rate, okay. I'll show you here as an example. So if these are the two successive QRS complexes, I will end up counting the number of large boxes, okay. The large boxes 1, 2, 3 and 4, maybe 4.5, right. So if I divide 300 divided by 4.5, it will come somewhere around, it will basically come between 60 and 75. So because 300 divided by 5 would have been 60 and 300 divided by 4 is 75. So between that, right? So that's how you will calculate the rate. So if you've seen an ECG and it shows tachycardia because you divided 300 by number of large squares between successive RRs, suppose you got only 2, you got, for example, only 2 large boxes between successive RRs, and when you divide, you will get the rate as 150. So definitely the patient has tachycardia, right? So this is how you determine the rate. Find out if there is tachycardia or not. If there is tachycardia, next proceed to determining how the QRS is. Is the QRS normal? That means is it narrow or is it wide? So you decide that based on the width of the QRS. If it is exceeding 3 small squares, if the width of the QRS is exceeding 3 small squares, then it becomes wide QRS. If it is narrow, it should be less than 3 small squares, okay. Next, look at the rhythm. Is it regular or irregular? And finally, look at P waves. Okay, is the P wave present or absent? If it's absent, it gives you different diagnosis. If P waves are present, but there are multiple morphologies, 3 or more different morphology of P waves, it gives you a different diagnosis. And look at the P and QRS ratio. Are they equal? For every QRS, is there a P? Is there a single P? Or are there too many P's? There are multiple P's for each QRS. Okay, I'll tell you the significance of all these shortly. So, for example, if the patient has a tachycardia, so you looked at the ECG, you are given an ECG, looked at the ECG, you calculated the rate. So, you need to be a little fast in this. You need to practice a little bit so that you can save time in your exams. Okay, so try and practice on ECGs. Look at try and calculate the rate on different ECGs. Okay, so 300 divided by number of large boxes. So it may be 300 divided by 3, 300 divided by 2. Sometimes it may be even 300 divided by 1. Right, so if the rate is very high, so you need to be well versed in calculating. So once you get tachycardia, look at the complex. If it's a tachycardia and the complex is wide, QRS complex I mean, okay, so QRS complex being wide with tachycardia, wide complex tachycardia at your level, even at INI level, always VT, okay, so VT is wide complex tachycardia. Then you proceed to what the question is asking. Is it only asking to diagnose? Is it asking for treatment? Is it asking for cause and so on? Okay, so if suppose the patient has tachycardia, there is tachycardia and it's narrow complex, and a narrow complex tachycardia, next you look at the rhythm. Is it irregular? So irregular narrow complex tachycardia narrows down the differentials. Very good, Dr. Med. Ventricular tachycardia. So it narrows down the differential diagnosis to either atrial fibrillation or one more. So what is the differential for narrow QRS complex, irregular tachycardia? What is the other differential apart from atrial fibrillation? So you may be, I'll give you clues. The scenario will be telling that the patient is a patient of COPD and the patient has taken perhaps theophylline group of drugs. So which arrhythmia would this be? Irregular narrow complex tachycardia. Matt, very good. Multifocal atrial tachycardia. So multifocal atrial tachycardia is a differential diagnosis for atrial fibrillation. The difference would be P wave. So that's why next you go and look at the P wave. If the P wave is absent, obviously the diagnosis becomes atrial fibrillation. If the P wave is present and there are multiple morphologies of P waves, then it becomes multifocal atrial tachycardia. Okay. In case the rhythm turned out to be regular, then again proceed and look at P waves. If the P wave absent, regular narrow complex tachycardia is PSVT. Okay, for your exams it is PSVT. PSVT is narrow complex regular tachycardia. Okay, the other differential for that would be atrial flutter. So in atrial flutter, you would end up getting multiple P waves for each QRS. Okay, so multiple P waves for each QRS. I'll show you these now. I'll show you these. Okay, let's proceed. Right. So what about this ECG? You guys can see it, I hope. Right, you can see them, you can make out the QRS complexes, and just visually looking at it straight away, you can almost tell that there is tachycardia, right? Even if you had to calculate, definitely sawtooth. Okay, yes, sawtooth appearance, very good. So definitely tachycardia. I hope you guys Agree? So in case we had to follow the same approach which we discussed. So if the rate definitely is showing tachycardia in this ECG. Next you look at the QRS. QRS, is it wide or narrow? Definitely it's wide, no, because it's lasting for more than 3, it's well beyond 3 actually. So, but more than 3 small squares, if the duration of QRS is more than 3 small squares, definitely it becomes a wide complex tachycardia. And then look at the rhythm. Okay, it's regular, right? There's hardly any irregularity. It's just too fast though, quite fast. So no question of irregularity. It's definitely regular, and you don't need this aspect. But anyway, looking at it, trying to look at it, is there P wave or not? Okay, so you can hardly make out any P wave. So this is not so important anymore, because just with the first 2 points itself, you are sure. If a patient in INI, if they give you an ECG and it is wide complex and tachycardia, think of ventricular tachycardia. Okay, so there itself you get the diagnosis, and then you try and decipher what they're trying to ask. Are they asking how do you treat such a patient? See, the problem is when the ventricles are contracting on their own like this, they're not waiting for the sinus impulse to come down. They're just autonomously contracting. So because of that, they'll not be filled with blood before they contract. So they may not end up producing enough stroke volume. So such patients very often end up becoming hemodynamically unstable. So such patients, when they have a ventricular tachycardia, they need to be given DC shock. Okay, so DC shock would be the treatment for any hemodynamic or unstable or instability in a patient with ventricular tachycardia. If the patient has normal hemodynamics, if the patient does not have shock or does not have hemodynamic instability, in that case you can go for medical therapies. Amiodarone would be your drug of choice. The other drugs like procainamide can also be used. Very importantly, in myocardial infarction, so if MI ends up producing ventricular tachycardia, which is one of its electrical complications, right? So MI has a number of complications. There is hemodynamic, there is mechanical, and there is electrical. So electrical complications of myocardial infarction, one of them is VT. So a patient with MI ends up producing or developing VT. The drug of choice in previous years used to be lignocaine, but that's no longer true. Okay, so the drug of choice for an MI related ventricular tachycardia is still amiodarone. Okay, so amiodarone, please choose amiodarone, not lignocaine. Please be clear on that. Okay, otherwise if the patient is, this is only if the patient is hemodynamically stable. Any ventricular tachycardia with hemodynamic instability, first thing you have to do is give a DC shock. Okay, so you give DC shocks to all arrhythmias which have a re-entry. So re-entrant tachycardia or re-entrant based tachyarrhythmias with hemodynamic instability, you can give DC shock because it will be effective. If it is not because of re-entry, so briefly I'll just mention arrhythmias could be either because of re-entry mechanism, or it could be because of enhanced automaticity, or it could be because of delayed, or rather after depolarization, delayed after depolarization or early after depolarization. After depolarizations basically. So in case it is because of re-entry, then you can break the circuit. When you pass a shock, when you give a DC shock, all electrical activity within the heart is going to cease. Okay, so the first tissue to recover would be the sinus. That's what you expect. When the entire heart is electrically inactive, the first tissue should be the pacemaker. The SA node should take charge and the sinus rhythm should get established. That's the principle of giving a DC shock. But otherwise, if in case the patient is having non-re-entry based arrhythmia, it will not be effective. If you would not be able to successfully, the chances are lesser. Okay, but of course you have to try. You can't be trying to make a diagnosis of the basis of the ventricular tachycardia. Maybe the ventricular tachycardia is because of enhanced automaticity, or maybe because of early after depolarization, like in patients with, it's called Torsades de Pointes, right? So patients with long QT, they can end up developing a polymorphic ventricular tachycardia. But nonetheless, if the patient is hemodynamically unstable, you need to give them a DC shock. It may not work, but still you need to try. Right, so re-entry based arrhythmias, re-entry can be micro circuit, micro re-entry or macro. Okay, micro re-entry include atrial fibrillation, AV-NRT. Okay, and macro include AV-RT. I hope you guys know a little bit about these, because I know this is all a lot to be expecting for you guys to be knowing, but a little bit if you guys know, maybe this can be a sensitization session where you can go and read up a little more in detail. Okay, for want of time, I will try to discuss as much as possible, but if you have doubts, you please ask me. Yes. Okay, so the drug for digoxin-induced VT. Okay, so digoxin-induced VT would again, you would have to rely on, if the patient is hemodynamically unstable, you would still have to rely on DC shock, basically electrical cardioversion. But if you can, then you can give digibind. Okay, so that's one of the previous year's questions where digibind FAB fragment was asked. Okay, but otherwise hemodynamically unstable, always go for a DC shock. Okay, so macro re-entry ventricular tachycardia would be another differential. Atrial flutter is again another type of macro re-entry arrhythmia. Okay, so all these would respond better for DC shocks. The others may not as much. Okay, so got it? Wide complex tachycardia, always think of ventricular tachycardia. Okay, what about this one? What do you think? How's the rate? Is the rate fine? Okay, don't be confused by this segment of the ECG. Look at only those beyond it. Okay, these and these. So, do you think the QRS is fine? It's narrow. These are less than 3 small squares? No, right? So, these are wide complex again. So, wide complex and there is tachycardia, done. Don't think of anything else for your INI. This is a ventricular tachycardia. Okay, wide complex tachycardia, ventricular tachycardia. Don't go beyond it. Okay, there will be AV dissociation. You may be able to make out the P wave or not, or you may end up finding that there is an irregularity. Like in this case, it's not entirely regular, so slightly irregular, but that doesn't matter. It's a VT. It's a wide complex tachycardia, it's a VT. But there's something different about it, right? Not all QRS complexes resemble each other. So, although they're wide and there is tachycardia, not all QRS complexes in terms of amplitudes as well as durations, they don't resemble each other, right? So, there are polymorphic ventricular tachycardia. So, polymorphic ventricular tachycardia is also known as, it's twisting around the central axis, no? So, a rhythm that twists around the central axis would be, I'm sorry. Okay. A rhythm that twists around the central axis would be, in the French. So this was a previous year's question. Okay, so this was asked last year in November. So this was, in May. So the previous year's question, they kept an ECG like this, where there were polymorphic wide QRS complexes that seemed to be different in terms of duration and length, and the rate was high. So this was a polymorphic VT. That's also known as Torsades de Pointes. Okay, the French pronunciation, Torsades de Pointes. Torsades de Pointes occurs generally after QT is prolonged. So, can you name some drugs that prolong QT interval? Name some drugs that prolong QT interval. So, I could have mentioned this earlier also. So, a patient who has collapsed after taking certain drugs, you would have to think of perhaps the underlying reason having been a Torsades de Pointes that was triggered by prolonged QT, right? So, it's called early after depolarization. So, what happens is, depolarization is represented by the T wave, right? So, if we had a QRS and then we have a T wave, and that's the depolarization vector. And then you're supposed to have a isoelectric segment then followed by a P wave. So, instead, if there was an early trigger and that ended up producing a QRS that landed on the previous T, that's called R on T phenomenon. So, R on T phenomenon. Okay, this is a little extra. You guys may not need this, but then just remember that when the QT is prolonged, the subsequent QRS may get triggered early, and that might end up falling on the previous T wave, and that is called R on T phenomenon, which can trigger. Very good, very good. A number of examples: quinidine, itraconazole, macrolide antibiotics. Very good. So if a patient is being treated for H. pylori infection and they've been given a course of 2 weeks of OAC, right? So omeprazole, amoxicillin and clarithromycin, and the patient ends up collapsing after 10 days of treatment, you need to keep in mind it might have been the macrolide, the clarithromycin, that triggered the QT prolongation. Okay, so generally, funnily, QT is calculated from the beginning of Q to the end of T. Okay, normally for men it is, the upper limit is 440 milliseconds, for women it is 460 milliseconds, so there's a difference. But what you should remember is what are the drugs that prolong QT, and QT funnily is prolonged by drugs which begin with Q. Okay, so like quinidine, Vishwanath, very correct, quinidine, quinolones and quetiapine. So these are some drugs that can prolong QT. So please take a history of this, any patient you encounter who has ended up developing this. So right, this would apply very similar to the previous example. The rate is high, the QRS is wide, wide complex tachycardia settles it. Okay, but funnily, this rhythm, when you see this rhythm, this has been asked in 3 different forms. In cardiology, you can see this kind of a pattern in 3 areas. One related to an arrhythmia, one related to the respiratory pattern, and one related to a murmur. So can you guys guess? All 3 are PYQs. All 3 have been asked in INI. One has been asked in NEET rather. So 2 in INI, 1 in NEET. So can you guess? If it's an arrhythmia that looks like this, it's twisting around the base, that's quite easy. You guys already guessed it. It's Torsades de Pointes. What about a respiratory pattern which resembles like this, or which is depicted like this? So there is gradually increasing depth of respiration, then followed by peaking, that means hyperapnea, and then progressively it reduces and it comes back down to apnea. So alternate cycles of apnea and hyperapnea, these are known as very good Vishwanath. It's Kussmaul's, rather it's not Kussmaul's, it's Saurabh who's answered. Very good. Saurabh has answered. It's Cheyne-Stokes. Very good. Cheyne-Stokes breathing. Cheyne-Stokes breathing. This is how it was depicted. Okay. This image was given and the question was identify the pattern of breathing. So Cheyne-Stokes respiration. Cheyne-Stokes respiration in cardiology. So the cause is heart failure. Heart failure can produce Cheyne-Stokes respiration. It's a type of central apnea, or rather central hypoventilation. Okay. Very good. The murmur has been identified by Dharani. Very good. That is aortic stenosis. So crescendo, decrescendo intensity of murmur. So you would have to end up placing S1 here and S2 here. Okay. So then it will end up making aortic stenosis. Very good. So you guys are doing an excellent job. So Cheyne-Stokes breathing. Okay. So remember this pattern when you see on an ECG twisting around the central base or central baseline, that is Torsades de Pointes. Wide complex tachycardia, always think of ventricular tachycardia. Okay, what about this ECG? So following our method, is there tachycardia or not? Quite clearly there is, no? So there is tachycardia. You can't see, if you can't see at least 3 large squares rather, if you can't see at least 3 large squares between successive QRS complexes, it is tachycardia. Okay, that much you can remember. Okay, so definitely not able to see 3 large squares between successive QRS complexes, definitely tachycardia. What about the complexes themselves? The QRS complexes, they're not more than 3, right? They're not exceeding 3 small squares. So this becomes a narrow complex tachycardia. So if it's a narrow complex tachycardia, next look at, is the rhythm regular or not? So looking at it, do you feel the RR intervals are fixed? The RR intervals, are they similar to each other, or is there a variation? Definitely there's a variation. So that means it's an irregular rhythm. So a narrow complex tachycardia with irregular rhythm comes down to 2 differentials, either atrial fibrillation or multifocal atrial tachycardia. So in this case, next you need to look at the P wave. If you are seeing 3 or more morphology P waves, different P waves, then it becomes multifocal atrial tachycardia. But if there is no P wave which is discernible, then it becomes atrial fibrillation. So can you guys make out where the P wave is in this ECG? Not quite, right? You can see certain deflections, but these don't represent, they're more like artifacts. Okay, so these are actually devoid of P waves. So absent P waves. So absent P waves with narrow complex tachycardia. Okay, rate is increased, tachycardia, narrow, rhythm is irregular, and P wave is absent. The diagnosis becomes atrial fibrillation. Very good. Very good. Nice. Okay, so you guys got it. So what will the situation be? Atrial fibrillation. So it might be a patient with rheumatic valvular heart disease, mitral stenosis, or the question may be about anticoagulation. So please remember CHAD-VASc, please read up CHAD-VASc scoring. Okay, so this is again yet another PYQ. And other than that, of course, even if the patient is hemodynamically unstable, this becomes a micro-reentrant type of tachycardia. Hemodynamically unstable, you need to give them cardioversion, DC shock. Okay, DC shock. If they are stable, then again you can decide. You need to anticoagulate them for at least 3 weeks before cardioversion, rhythm conversion, and then 4 weeks after the rhythm conversion. And then you can decide on the kind of antiarrhythmics you are giving. If the patient has hemodynamically stable and no structural heart disease, there's atrial fibrillation without structural heart disease, AFib without structural heart disease, then you can go for drugs like vernaculant. Okay, whereas if the patient has structural heart disease with structural heart disease, then you can go for drug of choice would be amiodarone. Okay, So these are the options you can choose for atrial fibrillation. Okay, clinically, what would you see? The A wave would become absent in. So in atrial fibrillation, there's absent P waves on ECG and absent A waves on JVP. Okay, this much you should remember. Again, since the atrium is not contracting, it's just fibrillating. So fibrillating atrium, you can't develop A waves in the JVP. You can't develop S4 also. So no S4. The fourth heart sound, remember, is produced because of atrial contraction against a non-compliant left ventricle, left atrial contraction due to atrial fibrillation. I'm sorry, the right atrial contraction. So if there is an S4, the contraction of the atrium should produce turbulence against a non-compliant ventricle. If that's not happening, then there'll not be any S4 because the atrium is just fibrillating. It's not contracting in unison. Okay, so these are the questions you can expect for atrial fibrillation, right? So what about this ECG? In this ECG, very good, Dr. Med, DC shock 200 joules. So this ECG, looking at it, there is tachycardia, yes, definitely. The rate seems to be lesser than, or rather it's greater than 100. The number of large squares seen between QRS complexes is less than 3. So definitely there is tachycardia. Is the complex wide or narrow? It's narrow. Correct? So narrow complex tachycardia, no doubt. How's the rhythm? Regular or irregular? It is yet again irregular. So you don't see that the RR intervals are constant. There are some which are wider, some which are narrow. So this kind of variable rhythm, that means irregular rhythm with narrow complex tachycardia. Next you look at the P wave. Are you able to make out P waves? Not clearly. Okay, not able to clearly make out P waves, which again ends up making it atrial fibrillation, right? So if the patient has a narrow complex tachycardia with irregular rhythm and the P wave is absent, it again becomes atrial fibrillation. So this is yet another example of atrial fibrillation, irregular rhythm with absent P waves, narrow complex tachycardia. Okay, so we've discussed about treatment, antiarrhythmics, anticoagulation. Anticoagulation, of course, you can go for novel oral anticoagulants, but there are two situations in which only vitamin K antagonists are used. So which are those two situations? Vitamin K antagonists are used, or compulsory rather. You can't use novel oral anticoagulants. Vitamin K antagonists are used for two situations, which are verapamil. Very good. You can use verapamil for atrial fibrillation in a hemodynamically stable patient. You can use even beta blockers, but these are more rate control drugs. So remember, atrial fibrillation, there is rhythm conversion, there is rate control, and there is anticoagulation. So three aspects that you need to try and cover. So verapamil would act as a rate control drug. Very good. So Saurabh Sinha says prosthetic valves, very, very good. So if it is a metallic valve, so if it's a metallic prosthetic valve and a moderate to severe MS, yes, very good. Moderate to severe rheumatic mitral stenosis is an indication for only vitamin K antagonists. Don't give novel oral anticoagulants. Very good. Right, so atrial fibrillation. Okay, causes of atrial fibrillation, several. Can be cardiac, can be non-cardiac. So cardiac causes you all know: ischemic heart disease, mitral stenosis, atrial septal defect. Even WPW syndrome itself can trigger atrial fibrillation. But non-cardiac causes include thyrotoxicosis and something called holiday heart syndrome. So you guys all know what is holiday heart syndrome. If you know, please comment. Right. So what about this ECG? Moving on to this next ECG, where you see again the rate, definitely not 3 large squares between successive RRs, that makes it tachycardia. QRS definitely not wide, so that makes it narrow complex. Is the rhythm regular or irregular? It is definitely regular. It's not irregular, right? So the RRs are not varying much. Are P waves present? P waves are present. Okay, so P waves are present. That makes it sinus tachycardia. Okay, so this makes it an example of sinus tachycardia. Would that be correct? Almost. Very good. Shanavas replying, alcohol binge causing atrial fibrillation. Very good. That's called holiday heart syndrome. Very good. Himanshu also. Okay. Though it seems, this ECG seems like it's regular, it's not. Okay, so if you observe closely, the RR intervals are slightly varying. If you look at this one and the next one, the RRs are varying. Okay, so actually it ends up becoming a irregular rhythm. So there is QRS that is narrow, there is tachycardia, but then there is an irregularity to it. So after that, you look for the P wave. Okay, so you look for the P wave, you are finding P waves in the first few complexes and then it goes missing, right? So here it's gone missing, here it's gone missing. Again, you're not able to find the P waves for quite some time. Then you find a P wave, but this P wave does not resemble this P wave. So you're seeing different types of P waves, right? You're seeing two P waves which don't resemble each other. You're seeing sinus, these are sinus only, or rather these are narrow complexes. So these are narrow complexes which have followed successive narrow complexes which have followed sinus rhythm, seeming sinus rhythms. Okay, so there was P wave here, there's no P wave here, yet the complex has remained narrow. So that means the impulse must be coming from the atrium only. So when there is 3 or more morphologies, even though it's missing, you can count it as there must be a P wave that has triggered this QRS here. So that means 3 or more morphologies of P waves, you will expect that this is multifocal atrial tachycardia. Okay, so rate is increased, QRS is narrow, rhythm is irregular. Okay, and P wave is present but 3 or more morphologies. So this makes it multifocal atrial tachycardia. In history, they'll give you clues like COPD, patient has COPD, and patient may have taken theophylline group of drugs which are arrhythmogenic. So remember, multifocal atrial tachycardia very rarely presents with hemodynamic instability. You don't expect that the patient with MAT would have a very high rate. It's very unlikely for them to have a very high heart rate, and therefore hemodynamic instability is not very common. So the question of trying to give them DC shock is out of picture. Okay, very good. More common in COPD patients. Very good, Sharon. Correct. So irregular rhythm, P wave is present with 3 or more morphologies, makes it MAT. If P wave is absent, it makes it atrial fibrillation. Right. So what about disc ECG? There is tachycardia. I hope you guys agree. Tachycardia definitely. Less than 3 large squares between successive QRS complexes. Next, look at the QRS complexes themselves. Do they appear wide or narrow? They appear narrow. Next, look at regularity. Do they appear regular or irregular? For the large part, they look regular only. The rate is quite high though. Okay, whenever the rate is very high, even if it's an atrial fibrillation, it almost appears regular when the rate is very high. So it's sometimes a little difficult. Practically, I'm saying. Otherwise, in this ECG, you have to take it as regular rhythm. So tachycardia, narrow complex, regular rhythm. Look at the P wave. Can you see the P waves? Where exactly are the P waves? Not really. Okay, so no P waves that can be made out, which means if the rate is high, if the QRS is narrow and the rhythm is regular and P wave is absent, that makes it automatically PSVT. Okay, paroxysmal supraventricular tachycardia. Narrow complex tachycardia with absent P waves, think of it as PSVT. Okay, so the question generally will involve adenosine. Okay, it will also involve adenosine in treatment of atrial fibrillation. So do you give in atrial fibrillation, do you give adenosine? No role. But in PSVT, definitely you give. Obviously, the first choice is carotid sinus massage. So if a patient has PSVT, the first act that you need to do is try and give them a carotid sinus massage, and that itself may revert the PSVT. So you're increasing the AV nodal refractoriness. That's what you do. When you give adenosine also, that's what it does. It transiently increases the AV nodal refractoriness. Therefore, it reduces the passage of the supraventricular rhythm into the ventricles. And then since the reentry circuit is broken down, the AV NRT reentry circuit is broken down, the rhythm reverts to sinus rhythm. Okay. So adenosine question is very common, either in atrial fibrillation where it's not supposed to be used, or in PSVT treatment where definitely it is to be used. Okay, you give them a flush of saline, you give them as close to the heart as possible. So if there's a central line, please give it through that. If not, if you're giving it in the periphery, you give it and immediately give a flush of saline. That's because adenosine acts for only how long? How long does adenosine act? So name a cardiology drug that acts for 6 seconds, name the cardiology drug that acts for 6 hours, and the cardiology drug that acts for 6 days. Very good. Dharani is absolutely correct. Dr. Med, absolutely correct. Asthma, yes. Asthma also may be associated MAT, but classically it's COPD. Vagal maneuver. Very good, Dr. Vishwanath. So the drug that acts for only 6 seconds, obviously you guys know it's amio. Very good, Saurabh. Amiodarone. But what about cardiovascular drug that acts for 6 hours? That's why the name is kept as Lasix. Okay, name itself is kept, the brand name I'm saying. The brand name is Lasix because the action lasts for 6 hours. and yet another drug which acts roughly for the duration of the platelet's lifespan. So platelet's lifespan is 6 to 7 days, no? So cardiovascular drug, you guys know it, I think you'll be answering. Very good. Digoxin. Okay, digoxin also, why not? Digoxin also has a very long half-life, even longer actually. It's a very long half-life. Yes, very good. Lasix. Lasix is furosemide. Okay, remember, treatment of acute heart failure. When a patient has pulmonary edema, the mnemonic is LMNOP, right? So L is loop diuretic, but sometimes we say Lasix. Okay, loop diuretic, that is furosemide. M is morphine, N is nitrates, O is oxygen, and P is position, right? So do keep in mind, Lasix is a brand name. It's a loop diuretic, that's furosemide, right? Okay, the advantage of furosemide, morphine and nitrates is that all three of them do produce some amount of venodilatation. Nitrate mainly act by venodilatation. Okay, so that is why they will end up reducing preload. That's how they act. That is also another pharmacology PYQ in the years gone by, right? So what about this ECG? Obviously the rate in this is not very high, so you can't say that this is tachycardia, correct? It's not less than the number of large squares or large boxes between successive QRS complexes, not less than 3, so it's more than 3. Okay, so it's probably 4, right? So almost 5, so 5 almost large squares, so it's not tachycardia. But still, since we're discussing tachyarrhythmias, we will continue. So in this, if it is is it a wide complex or a narrow complex tachycardia? It's not a tachycardia, I know, but let's presume that there is tachycardia. So this is a narrow complex rhythm. Okay, so the rhythm is narrow complex. Next you look at the regularity. Is it regular or irregular? It is regular. Okay, so regular narrow complex rhythm presumed to be tachycardia for purpose of discussion. Next look at the P wave. Is the P wave absent? If it was a narrow complex tachycardia and with regular rhythm with absent P waves, you would have thought of PSVT. But here the P waves are definitely there and in abundance. Okay, there are more P waves than QRS complexes. So too many P waves, less QRS complexes, narrow complex tachycardia with regularity. Then you have to think of atrial flutter. Very good, sawtooth pattern. F wave, right? So rate is increased, narrow QRS, rhythm is regular, and P wave more than, so P to QRS, if you take a ratio of P to QRS, the ratio is more than 1. So more P waves than QRS complexes. That is atrial flutter. You can easily make out the P waves, definitely. It's not atrial fibrillation. It has to be atrial flutter. Okay, so what is the history that they'll give you? Post cardiac surgery. So cardiac surgery, the most common arrhythmia after cardiac surgery is atrial flutter. Okay, so you can revert this with DC shock also. Just 50 joules of DC shock would be enough. It's a reentrant tachyarrhythmia, no? So that's why you can just give it's a macro reentrant tachyarrhythmia. Okay, so that is atrial flutter, right? So F waves, these are called F waves. Where else do you see F waves? You see F waves in nerve conduction studies in case of GB syndrome. Okay, GB syndrome also F waves would be either delayed or maybe absent. Okay, F waves in nerve conduction studies as well as in ECG. ECG, it is atrial flutter. Okay, right, very good. All of you are doing very well in identifying the rhythm disorders in these ECGs. Okay, what about this one? So clearly it's not a tachyarrhythmia. It's in fact quite slow rhythm. So number of large boxes between successive QRS complexes is quite many, right? So this is a quite slow rhythm. It's a bradycardia. But apart from that, if you notice, what else is abnormal? I know that the QRS is wide, but for the time being, focus on this. What is this? I'll give you a clue. So this abnormality is actually considered a minor criterion. So minor criterion in diagnosis of rheumatic fever. Okay, acute rheumatic fever diagnosis, modified Jones. It's a minor criterion provided that carditis is not major. As long as carditis is not a major criterion, you can use this prolonged PR interval finding as a minor criterion for modified Jones diagnostic criteria for acute rheumatic fever. Okay, so this is nothing but first degree AV block. So remember, PR interval being prolonged should be first degree AV block. Okay, so yes, first degree AV block. One of the clinical manifestations you will see is S1 being soft. Okay, because as the AV node refractoriness increases, the PR interval increases, the closure of the mitral valve gets delayed, and that is why the S1 becomes softer. So a soft S1 is a clinical manifestation of prolonged PR interval, which is first degree AV block. Okay, next, what about these two? This was a question in INI November 2023. Okay, November 2023, this was the question. So this rhythm you can see PQRST, 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 and then P, then nothing, and then again PQRST. So what happened before that? Definitely you can notice that the P wave didn't get conducted in both these. Okay, very similar here also. Both these P waves didn't get conducted. But what's happened before that? So very good. Second degree. So undoubtedly there is a heart block, and it's a second degree heart block. The moment there are sinus rhythms or sinus complexes, but in between there are missed or unconducted P waves, they become second degree heart block. First degree heart block, there is no unconducted P waves. Every P wave is getting conducted, just that the conduction is slowed down in the AV node. That's why there is a prolonged PR interval. Whereas in second degree AV block, intermittently there will be P waves which are not getting conducted, like this one. So this P wave didn't get conducted. Likewise here. That's why you didn't have a QRS following it. So there are dropped complexes or dropped conductions, and therefore this has become second degree AV block. If you look at the first one, the PR interval has successively gone prolonging. Okay, the PR interval kept getting prolonged. Finally, there was a missed unconducted P wave. So this is what is Wenckebach's. Very good. Wenckebach phenomenon type 1. Mobitz type 1, that is. Okay, second degree Mobitz type 1. Also known as Wenckebach's phenomenon. Whereas in the second ECG, you can notice PR interval never changed, and out of the blue, a P wave got dropped. That means P wave didn't get conducted. The sinus rhythm or the sinus node generated the P wave, but didn't get conducted via the AV node to the ventricles, and therefore there was no QRS, it went missing. Okay, so this is an example of Mobitz type 2. This is Mobitz type 2. So please remember, if the PR successively prolongs and then the P wave doesn't get conducted intermittently, that is type 1. Mobitz type 1, second degree. This is indeed second degree. Whereas if the PR remains constant and intermittently, rather out of the blue, okay, you can't predict it. Sometimes if it continues like this, for every 4 P waves, 3 are conducted, 1 is missed, then it's fine. You can predict when it's going to be missed. But then sometimes it's very haphazard, it's random. So you may get 2 P waves conducted, the third one not conducted. That will be followed by 3 P waves conducted and the fourth one not conducted. So it can vary a lot. And that is the problem with Mobitz type 2. I'm sorry, I've written type 1. I'm sorry. So yes, so that is the problem with Mobitz type 2. It ends up, it's a high block. That means it's an infranodal block. So it's in the bundle of His. So any further, if it continues to get blocked like this, it will very high risk of going into a complete heart block, that is third degree AV block. Okay, third degree AV block is going to be characterized by like this, right? So third degree AV block, there is going to be AV dissociation. Okay, so AV dissociation. So you can make out the P waves are coming by themselves. Okay, P waves are coming by themselves. They have no relation to when the QRS is coming. So QRS is coming very delayed and it's wide. It's wide because the ventricles are now trying to generate their rhythm. So ventricular tissues, their pacemaker activity is very, very less. Very, very low compared, and they never needed it because every time the sinus used to send the impulses down through the AV node. Now if the AV node is totally blocked, it's not allowing any sinus impulses to come down into the ventricles. In that case, you will get a ventricular rhythm that will be wide complex and will be very slow. And it can be fatal also if the ventricle doesn't generate. If it fails to generate its rhythm, then it's as good as the atrium may be contracting, but the ventricles are not. It's as good as patient developing asystole, right? So ventricle has to contract. Something has to allow the ventricle to contract. If not the sinus rhythm, it has to generate its own. If it fails to, it's fatal. So that's why we are always worried when there is a second degree Mobitz type 2 block or a third degree, that means a complete AV block. Okay, so wide complex, and you can make out when the QRS is wide, no, when it's coming from the ventricle, the T wave, the corresponding, there will be discordance. Okay, the T wave will go in the opposite direction. If it's a positive QRS in the same lead, the T wave will become discordant. It will become negative. That means it's coming from the ventricles. Right, so this is third degree AV block. What is the JVP sign you see in third degree AV block? So AV dissociation is not exclusive to heart block. So if the patient is having bradycardia with AV dissociation, think of third degree AV block. If the patient is having tachycardia with third degree, or rather with AV dissociation, then you think of ventricular tachycardia. So ventricular tachycardia also there is going to be AV dissociation, but in that case it's the ventricles that have gone rogue. They are acting when they're not supposed to, so they are contracting at a high speed. So the ventricular rate would be greater than the atrial rate, whereas in third degree AV block, the atrial rate would be greater than the ventricular rate. So that is why, because the AV node is blocked. Okay, so both these, because of the AV dissociation, what JVP change would you see? Absent A wave would be a finding in atrial fibrillation, where the contraction of the atrium is lost. Now it's only fibrillating. So fibrillating a right atrium cannot produce an A wave. So absent A wave is a finding of atrial fibrillation. Giant A wave. Good attempt, Brijesh. The problem is terminology. So giant A wave is not entirely wrong. It's just convention that it's called Canon A waves. Very good. So Dr. Med, very correct. Canon A waves is what is the technical term you use for the JVP change that you see, the A wave that you see in patients with third degree AV block because of AV dissociation. Okay, so what would happen is intermittently the atrium would end up contracting at the same time as the right ventricle. So right atrium and right ventricle contract together. That is because they are dissociated. Their contraction, their rhythms are not related. So intermittently they'll contract together. So the right atrium would end up contracting against a closed tricuspid valve, and that will produce Canon A wave. So Canon A wave is a technical term, but you're not wrong in saying giant A waves. But for your exams, remember it as Canon A waves. Giant A waves is what you associate with tricuspid regurgitation. Tricuspid regurgitation. Okay, I'll come shortly to JVP discussion also. That's also important. Okay, clear? Large A waves. Yes. So quickly revising what we have learned. So if there is ventricular tachycardia as a rhythm, you will expect the rate will be high, the complex would be wide, the rhythm would be regular. For the most part, it will be regular. P waves, actually, it's not very important. You may be able to make out. It will be AV dissociation if you are able to make out. And again, this also is not relevant. So just with these 2 points, you should be able to make a diagnosis of ventricular tachycardia, wide complex tachycardia. Okay, atrial fibrillation, there will be tachycardia. The complex would be narrow. It would be irregular, and A waves will be absent. Okay, A wave absent. That is atrial fibrillation. PSVT, tachycardia, narrow complex, regular, again absent. That is P waves. Okay, but MAT, tachycardia, narrow, irregular, 3 or more morphologies. Okay, atrial flutter, again tachycardia, narrow, regular. The P waves are present, but the ratio between P to QRS is more than 1. Okay, I'm sorry, more than 1. Right, and then the 2 heart blocks. So this is only when you're seeing an irregular rhythm. So in between there are some QRSs that are not manifesting. Then you'll think of an irregular rhythm. But generally these will be associated with rather bradycardia. Okay, at least the tachyarrhythmias you try and be able to appreciate based on this small table. Okay, so try and put it into practice. It's always it takes time, but with practice it gets easier. Okay, so right, just a revision. Tachycardia, QRS is wide. Think of ventricular tachycardia. Questions would be about treatment. Hemodynamically unstable, DC shock. Stable, can go with amiodarone procainamide, especially if it is post-MI. Narrow complex, look at the rhythm. If it is irregular, could be AFib or MAT. AFib, number of manifestations, number of points important. Okay, multifocal atrial tachycardia, COPD related. Regular and narrow complex, absent P waves, think of PSVT. Treatment is initially vagal maneuver and then adenosine. Okay, atrial flutter, post-cardiac surgery. Okay, that is about tachyarrhythmias. Moving on, I think we're going a little slower than I planned. Anyway, so this is the JVP. You guys know about the different waves in JVP. So the A wave is because of atrial contraction. C wave is because of the contraction of the right ventricle. So this was a PYQ where they asked, what does it coincide with? The C wave coincides with what? The answer would be isovolumetric contraction of the right ventricle. Okay, so the isovolumetric contraction of the right ventricle is what produces the C wave. Okay, so X is because of atrial relaxation. So the atria are trying to relax and become ready for receiving the blood that comes in through the pulmonary, or rather through the systemic veins, and that produces V. So when the atrium is getting filled, the right atrium is getting filled with the venous return, that time it will produce the V wave. So V for venous filling the right atrium, Y is for atrial emptying. Okay, the atria, that's because the tricuspid valve opens, the atria empty into the ventricle, and that produces the Y wave, the drop in pressure. Okay, the drop in pressure is the Y wave. What is important is, apart from these kind of questions which they asked about timing, okay, so obviously A wave would be after P wave in the ECG, right? P wave is what produces atrial depolarization, that will finally get coupled, electromechanical coupling, and then produce atrial contraction. The atrial contraction is what produces A wave in JVP. So the P wave in ECG will precede A wave in JVP. This is again another PYQ, previous year's question. And as I said, C wave timing is with isovolumetric contraction of the right ventricle. But apart from all these, the abnormalities in JVP we already discussed. Atrial fibrillation, absent A wave. Okay, atrial fibrillation is a condition where the A wave is absent in JVP and P wave is absent in ECG. Okay, giant A wave, tricuspid regurgitation, and tricuspid stenosis rather. Okay, so tricuspid stenosis also produces a giant A wave. Even regurgitation could produce it, but it's more classical for, I'd rather say it's more classical for tricuspid stenosis. I'm sorry, tricuspid stenosis. Okay, Canon A waves would be seen, as we said, in AV dissociation, third degree AV block, and CV wave, Lancisi sign, these are seen in tricuspid regurgitation. So CV wave is a more prominent or a more important finding in patients of tricuspid regurgitation rather than a giant A wave. Giant A wave is for tricuspid stenosis. Okay, prominent X descent is something that you see in patients of, so remember the mnemonic pay tax. Okay, so in this is where it's prominent. Okay, so X wave will be prominent in cardiac tamponade. Okay, whereas Y wave will be what is prominent in constrictive pericarditis. Okay, so pay tax. So in prominent X descent it is tamponade, prominent Y descent it is constrictive pericarditis. Okay, and obliterated Y descent is something that you get in tamponade again. So tamponade, the X is prominent but the Y is obliterated. Okay, so these are the abnormalities that you associate with JVP. These kind of questions would be anticipated. Okay, clinical questions are invariably they will ask. In INI, they love asking clinical based questions. Okay, so identify the abnormality. This was the ECG that was asked in the November INI, and it was a second degree AV block, Mobitz type 2 second degree AV block. So if you notice, PR interval not changing, and the P wave, which is hidden here, that it doesn't get conducted. So that is without the PR interval changing, and that is Mobitz type 2. Okay, second degree infranodal block. So infranodal, okay, it's in the bundle of His, below the level of the AV node, right? Okay, so during which phase of the cardiac cycle would you anticipate the aortic regurgitation murmur to be heard? Okay, is it systole or diastole? Aortic regurgitation. So basically the ventricle, when it contracts, systole, right? So when the left ventricle, we mainly discussed left ventricular or left-sided valvular heart disease. So when the ventricle contracts, there is going to be the blood flowing through the aortic valve with the closure of the mitral valve, correct? So there's no blood coming, there should be no blood coming through the mitral valve from the left ventricle into the left atrium, and the blood should only flow through the aortic valve, and that is systole. Okay, so instead, if during the contraction of the left ventricle there is blood flowing not just through the aorta but also into the left atrium through the mitral valve, it becomes mitral regurgitation, correct? So that means mitral regurgitation murmur, you hear it in systole. Whereas in aortic regurgitation, the blood will flow from the aorta into the left ventricle. So obviously it can't happen during systole, because systole is generating a lot of hemodynamic pressure. So the blood cannot be flowing back during systole. It has to be during diastole, right? So it's a diastolic event. So if you had to depict the murmur, you would be depicting it somewhat like this. It's after S2, it will be a decrescendo murmur. Okay, early diastolic murmur. It's an early diastolic murmur. Whereas if you are given a murmur which is depicted like this, what would it be? So between S2 and the subsequent S1 is the diastole, correct? This is the diastolic period between S2 and the subsequent S1. So if the murmur began strong and then subsequently weaned off, that would be an early diastolic murmur of AR. Very good. Early diastolic murmur in severe AR can produce Austin-Flint murmur, which is an MDM. Very good. Very good. Very good, Dr. Med. Yes, that is true. But in comparison to this, what would this kind of murmur be depicting? Where it starts off in the mid diastole, like I told you. So diastole of the left ventricle is when the blood from the left atrium is supposed to flow through the mitral valve. So if there is turbulence around that time, that would be because of mitral stenosis. Very good. So there will be a mid diastolic murmur. It's a rumbling murmur, low pitched, and there will be a presystolic accentuation. So once the left atrium contracts, this presystolic accentuation, so the left atrium contracts, the presystolic accentuation occurs. So this is yet another phenomenon that is lost in atrial fibrillation. So in atrial fibrillation, if the patient has a mitral stenosis, you lose the presystolic accentuation. You lose the A wave in JVP. You also lose any chance of S4. Okay. Correct. Very good. So diastolic murmurs, there are two. MS is mid diastolic with presystolic accentuation, and aortic regurgitation, which has a decrescendo pattern. But if, like we discussed, mitral regurgitation, during systole, the blood is flowing from left ventricle into the left atrium. It's not supposed to. The mitral valve is supposed to be shut tightly, but it's not. It's damaged, it's incompetent, it's allowing backflow. So that will happen throughout the systole because the left ventricular pressures will be elevated in comparison to the left atrial pressure throughout the systole. So pan-systolic murmur is what you associate with mitral regurgitation. Whereas, as we already discussed, if there is a crescendo decrescendo murmur in the systole, it is aortic stenosis. So aortic stenosis, mitral regurgitation, aortic regurgitation, and mitral stenosis. Okay, so these are the phonocardiographic representations. Okay, so yes, the murmur is likely to be heard during early diastole. That would be the right answer. But you can hear an Austin-Flint murmur also because of severe AR. Very good. Okay, yet another clinical based questions. Absent loud, or rather the S1 is not loud except which condition? So in mitral stenosis, you expect a loud S1. But in case there is a certain condition where it's not loud, which of these would not be one of them? That means basically which condition would the S1 continue to remain loud, whereas the other three, it will remain soft or it will turn soft despite there being a severe MS. Severe mitral stenosis, definitely you expect a loud S1. Do you expect in mild MS, or do you expect it in valvular calcification if the mitral valve is calcified, an associated MR, or post valvotomy? Okay, this was the trick question they expected students to fall for, but most of you have not. All of you have not. So that's very good. MS. So mild MS is not a condition where it will become soft. Mild MS also, it will remain loud only. That's because the left atrial pressures are higher because of mitral stenosis. The closure of the mitral valve occurs slightly later rather. So because of delayed closure, it shuts with a higher force because that is the time where the left ventricle is contracting at a very high pressure. So the rate of rise in pressure, left ventricular pressure, would be higher at that point. That's why it will shut the mitral valve with more force. That's why the S1 is louder. In mild MS also, okay, in mild MS, moderate MS, severe MS, the S1 remains loud. Okay, valvular calcification softens it. If there's a development of MR, either because of the valve lesion itself or whether it is because of post-valvotomy slight amount of mitral regurgitation, that these can end up leading to soft S1s. Okay, so absent loud S1, that means S1 being soft, can be seen in all except mild MS. Mild MS, it will still be loud. Okay, this is how they had asked this exact question, which was asked in May last year. Okay, so expect these kind of questions based on clinical cardiology. So they want to see if you guys have attended your clinical postings and been asked these kind of questions by your examiners. Okay, calcification leads to soft S1. Okay, even if a patient has severe mitral stenosis, once the valves get calcified, they're not going to move much. So they're not going to be shut or even open with too much mobility. So that's why it will end up producing a soft S1. Right. Okay, so next question. This has been asked repeatedly now almost every year they ask about NSTEMI treatment. So NSTEMI treatment, remember, if it's a stable plaque, okay, a stable plaque rich in lipids but has a good fibrous cap, not going to rupture anytime soon, producing stable angina. So stable plaque, stable angina, effort dependent angina, that means you want to prevent it from progressing. You want to reduce the lipid content, so you will give them statins. This is what you do to prevent any further worsening. You will also give them you end up giving them antiplatelets. Okay, so antiplatelets, just to make sure that even if there is a small rupture, there is not going to be any aggregation of platelets there. What if it's an unstable angina or NSTEMI? That means this plaque has now gone on to rupture, and because it's ruptured, it's exposed its internal contents to the serum, or to the plasma rather, and that is why all the inflammatory markers or inflammatory cells would be activated and platelets would be activated, right? So because of platelet aggregation, now there's a risk that this ruptured plaque is going to occlude the entire vessel, and if you want to prevent that, you will obviously give them antiplatelet also, but you have to prevent the next step. If this continues, platelets are the first responders, but after bleeding time comes clotting time, so you don't want that clotting time to get activated, right? So that means the coagulation factors, you don't want them to get activated, so you have to give them anticoagulants. Okay, so anticoagulation is a must for NSTEMI. Otherwise, once there is activation of the coagulation cascade, this will turn into STEMI. Okay, you don't want that. So if there is a complete occlusion of the blood vessel because of a fibrin rich clot getting deposited, that's going to be disastrous, right? So it's going to occlude the entire vessel. So you don't want an NSTEMI or an unstable angina to turn into a STEMI. So to prevent that, you have to give anticoagulation. So the options here, apart from antiplatelets, you do need to give anticoagulation. Repeat question several times. Okay. Biomarkers. So please remember the important biomarkers. Now it's mainly troponin. So you define myocardial infarction, whether it's STEMI or NSTEMI. Definition is based on biomarker elevation. You need to demonstrate a rise or fall in cardiac biomarkers with at least one value being above the 99th percentile for that particular biomarker. Usually we use cardiac troponin, either troponin I or troponin T, right? Please also remember heart fatty acid binding protein. If you are asked which is the biomarker, cardiac biomarker which is earliest to rise, it is heart fatty acid binding protein. Okay, cardiac myoglobin would also come close, but this is the more reliable one. What is the mechanism of Brilinta? Is it? Can't see this. Brilinta is ticagrelor, no? So ticagrelor, these are antiplatelets. These are P2Y12 inhibitors. So P2Y12, this is important for platelet aggregation. So it's an adenosine receptor. So adenosine, it gets released once platelets adhere to the endothelium. No, when there's an endothelial damage, that's going to end up freeing up the von Willebrand factor. So von Willebrand factor will come, it will pull the platelets towards it and attach to that platelet. That's called adhesion, platelet adhesion. And once that happens, platelets will start producing adenosine, and that adenosine will start binding other platelets to it, and that is called platelet aggregation. So adhesion, aggregation. So this aggregation can be prevented if P2Y12 inhibitors are given. P2Y12 is the receptor. So you want to give antagonists to this, and one of them is ticagrelor or Brilinta. Brilinta is the brand name. Okay, so yes, clear? Stable angina, give them statins, give them antiplatelets, prevent NSTEMI. If there's NSTEMI, you want to prevent STEMI, give them statins, antiplatelet along with anticoagulation. Keep that in mind. Okay, if there's STEMI, take them up for coronary angiogram. Door to balloon time, 90 minutes. Okay, angioplasty. Right. I'm sorry, these are things that I've already written down. I will discuss them though. Right. So next question was a patient with dyspnea, cardiomegaly, rails on auscultation, which are the, so it's basically heart failure treatment. What do you give them? So in an acute heart failure, it's always LMNOP. You don't have to start anti-remodeling drugs straight away for patients with acute heart failure. Wait for them to stabilize, wait for them to become euvolemic. Okay, when they're having rails on auscultation, you can't give them drugs which have negative inotropic effect, right? So you cannot give them carvedilol, you cannot give them beta blockers if they are currently having pulmonary edema features. So obviously carvedilol goes out. Digoxin, the current role for digoxin right now is in patients of refractory heart failure with tachycardia. Okay, if there is a tachycardia and refractory heart failure, if all other measures have failed, then you can give digoxin. Otherwise, very, very seldom used. Okay, digoxin is not used much. Okay, furosemide must be initiated first. So furosemide, what would you say? If the patient is having pulmonary edema, LMNOP, right? So loop diuretic, furosemide has to be the first drug of choice. So this is again similar to yet another question that was asked in NEET, where they had given an image of pulmonary edema and they had asked about what is the first drug to be given, that is furosemide. Okay, captopril is an ACE inhibitor, very good anti-remodeling agent, but this is not the time, not when the patient is having pulmonary edema. Let the patient become euvolemic, you can initiate them, because when you give them furosemide, the blood pressures may drop. So you have to watch for all that. You can start the anti-remodeling drugs later. Okay, so remember the anti-remodeling drugs, the latest one is sotagliflozin. It's a combined SGLT1 and 2 inhibitor, and it's been approved for usage in heart failure. Vericiguat is cyclic GMP stimulator. Okay, GS stimulator. Okay, so vericiguat sounds like riociguat, no? Vericiguat is both acts very similarly. It's a GS stimulator, guanylate cyclase stimulator, which is used for heart failure. Vericiguat. Riociguat is used in pulmonary hypertension. Okay, and remember which are the drugs which have mortality benefit in heart failure. These include beta blockers including carvedilol. So which are the beta blockers which have cardiac mortality benefit in heart failure? Which are the beta blockers which have cardiac mortality benefit in heart failure? You can remember it as carvedilol, metoprolol and DASH. So you guys can tell me in the comment section which are the third beta blocker which has mortality benefit in heart failure. Other than these, of course, ACE inhibitor, ARB, these are the first agents to be started. And first anti-remodeling agent to be started in patient with heart failure is always ACE inhibitor or ARB, preferably ACE inhibitor. ACE inhibitors are better at reducing the chances of left ventricular hypertrophy development. Okay, rather if I'm sorry, Dharani, glaucoma was for mentioning for glaucoma. Okay, so yes, other than these, of course, we have SGLT2 inhibitors. They have proven mortality benefits. We have mineralocorticoid receptor antagonists. Please remember finerenone is the recently approved drug, recently in the sense been more than a year, and bisoprolol, very good. So please remember bisoprolol, cardiac mortality benefit. Okay, carvedilol, metoprolol and bisoprolol, these are the beta blockers which have cardiac mortality benefit. Also remember hydralazine, this is out of the blue, right? So hydralazine, combination of hydralazine plus isosorbide dinitrate and hydralazine combination also has mortality benefit, although individually neither of them have it, but as a combination they've been proven to have mortality benefit. So just like that, so when you're reading for INI or when you're reading for entrance preparations, no, whenever you get the chance, revise. Whenever you can connect the dots, connect. Okay, so you came across hydralazine, immediately think of what are the other important points about hydralazine. It's a vasodilator, fine. So hydralazine has mortality benefit only with in combination with isosorbide dinitrate, no problem. But apart from this point, what else is important? Hydralazine is very often associated, it's a high propensity to develop drug-induced lupus. So drug-induced lupus. Okay. Hydralazine. So what are the other drugs that can produce drug-induced lupus? Hydralazine, procainamide. We discussed procainamide in ventricular tachycardia. And drugs like INH, drugs like phenytoin. Okay, all these are drugs which can have a tendency to produce drug-induced lupus. Remember, if a male patient develops lupus, always think of drug-induced lupus. They must have received one of these drugs which ended up producing their joint pains, their pleuritis. Okay, these are manifestations. Drug-induced lupus, positive for which antibody? Specific antibody for drug-induced lupus. And final thing about hydralazine, pregnancy. Very good in pregnancy. Pregnancy, you can also use beta blockers. You should not use ACE inhibitors. That is again another PYQ. Right, so you get a chance, you saw hydralazine, you try and relate to where else did you see hydralazine, what are the important points about hydralazine. The more you can do that, the easier it will be for you to revise. So it's not like you give one reading, everybody reads for one time. One reading everybody does. Okay, so what makes the difference is how how many times you're able to revise, how well were you able to revise. So it's not about the entire content having to be finished. Even if you read only 70% of what you're supposed to, what you plan to, but that 70% you revised very well, will make the world of difference. Okay, so that's why we snuck in a revision point about hydralazine. I'm sorry. Yes. So one more question which was asked: Bath syndrome defect is seen in cardiolipin. It's actually tafazin protein, but cardiolipin is important for tafazin functioning. And cardiolipin, the other important points include that the anticardiolipin antibodies are important antiphospholipid antibody syndrome, as well as in it's what is tested for VDRL, right? So in VDRL, you test for anticardiolipin antibodies, and that's why you get false positive VDRL test in patients with antiphospholipid antibodies. Very good. Dharni has answered anti-histone antibodies. Very good. SHIP, sulfa drugs. Yes, sulfa drugs and hydralazine. Yes, INH. These are the drugs which can produce drug-induced lupus. Okay. So this was again another question. Bath syndrome. So titin gene mutation can produce dilated cardiomyopathy. Okay, I'll give you a short break. Okay, I don't want to be too monotonous also. Although I really like discussing medicine, but I can understand for the other person it might seem a little dry. So I always try and put a few bits here and there to try and make it a little interesting and break the monotony. So likewise, what do you think, which disease is this describing? So you can see that there is an octopus which has gone off on a hot air balloon ride from the apex of the mountain, and now it is seeing a stunning view, so much so that stunning view has almost broken the octopus heart, and the octopus is sitting on a pot also. So what could this be? While you think about it, I'll also show you this one. What do you think this is? So the left ventricle is telling the right ventricle that the body has grown fatter. Okay, very good. Dr. Med, Dr. Potter, very good. You guys are right. This is Takotsubo cardiomyopathy. Very similar to myocardial infarction, Takotsubo cardiomyopathy, the patient would have received some bad news, and that would have triggered off acute chest pain, very intense, and they may even go into shock. So they brought to the emergency room, and then because they have chest pain, you did the ECG. ECG showed ST elevations, not necessarily contiguous ST elevations, contiguous leads. Okay, they may represent different areas of the heart. Okay, for example, lead 1 and lead 2 will have ST elevations. Lead 1 and lead 2 don't represent the same area of the heart. No, lead 1 represents a left side, it's a left-sided lead. Lead 2 is an inferior lead. But non-contiguous leads with ST elevations, that is when you start doubting. But still, you got ST elevation, you sent cardiac enzymes. The cardiac enzymes came back positive. The patient has elevated cardiac enzymes. By definition, if the cardiac enzymes are positive and the ECG changes are there, that is universal definition of myocardial infarction. So you are really worried. You did an echo also, just to be sure. An echo also showed wall motion abnormalities. So everything is pointing towards myocardial infarction. Okay, what wall motion abnormality you see is a stunned myocardium. A stunned myocardium where the apex would be ballooned. Okay, so the apical ballooning is seen. Apex is ballooned, whereas the free wall would be hyperkinetic. So a hyperkinetic free wall with apical ballooning is what is seen in patients of Takotsubo. So all this led to you having to end up taking the patient to angio, and in the angiogram is where you would discover that there is apical ballooning. I am so sorry, Dr. Potter. I'm sorry for your loss, for what you mentioned. But that's how it is. This Takotsubo can be very, very similar to myocardial infarction. You only discover it on angiogram that there was an apical ballooning and not a coronary or a coronary artery blockage. Okay, so very close differential to myocardial infarction. And you guys are right, this is no doubt arrhythmogenic right ventricular dysplasia. Okay, again, yet another situation where the patient will have sudden collapse. Look for epsilon waves. Okay, it's a misnomer. It's not just restricted to right ventricle. There will be fibrofatty tissue. So this is common in cardiomyopathy or rather muscle disorders, right? Is there a skeletal muscle disorder where because of a protein defect, the muscle gets replaced with fibrofatty tissue, leading to pseudo hypertrophy? A skeletal muscle disorder that also can be associated with a dilated cardiomyopathy. You guys can tell me. Okay, so hypertension based questions. If a patient has hypertension with elevated blood glucose levels, what antihypertensive would you prefer? Hydrochlorothiazide, the problem with hydrochlorothiazide is thiazides can inhibit insulin release, can aggravate blood glucose control, or rather can worsen blood glucose control. Therefore, to avoid that, metoprolol likewise not preferred as a first line antihypertensive. Among the first line antihypertensives, the only other choice is telmisartan. Telmisartan has additional gamma PPAR activity, agonistic activity, and therefore in diabetics it's a preferred ARB. Duchenne's, very good. Duchenne's muscular dystrophy is definitely what is a similar pathology where there is replacement of muscle tissue with fibrofatty tissue that leads to pseudo-hypertrophy of calves. Okay, clonidine, definitely not a first-line antihypertensive. It has limited duration of action. You need to give it multiple times, and sudden withdrawal can lead to rebound hypertension. So, not preferred as a first line. Can be given for resistant hypertension. Resistant hypertension was also asked. I think it was last year or maybe in 2022. But resistant hypertension was asked, and which class of diuretics must the patient be taking? So the definition was given 3 or more antihypertensives, including at least one dash. Okay, which class? And the answer was diuretic. So they should be taking at least one diuretic along with 2 other antihypertensives at their maximum tolerated doses, despite which their blood pressure is not under control, for us to call them as resistant hypertension. In patients with resistant hypertension, the first additional antihypertensive you add is not clonidine, but mineralocorticoid receptor antagonist. Okay, mineralocorticoid receptor antagonist. Goversine, very good. Goversine is what is seen in patients of Duchenne's. They try and climb upon themselves. Right, so cardiology, I barely scratched the surface, but that's how it is. I need to finish today's session as much as possible, so I will continue. Please don't think that whatever I have discussed is the only thing that you need to focus on. This is just a guide for you guys to try and stimulate you to revise. I hope you all are revising. As I said, please revise what you have read. Okay, just a month before exam, if you are seriously appearing for INI, don't read anything new. Just revise what you've already read. You've already read a lot. Okay, trust yourselves. You've forgotten, that's all. It's a natural thing. It happens to everybody. What you read today, 20 days later, you will not remember it. That's how it is. That's the nature, the volatile nature of what we are trying to, or what you guys are trying to read up. Okay, spironolactone given in start. Restart. Okay, yes, correct. So basically you give aldosterone antagonists, mineralocorticoid receptor antagonists for patients with resistant hypertension, because Conn syndrome is quite common. It's underdiagnosed. Okay, so increased aldosterone secretion may be the reason for the resistant hypertension. OSA, obstructive sleep apnea, is again another cause of resistant hypertension. Okay, so unless OSA is corrected, the resistant hypertension may not. So secondary causes of secondary hypertension, you guys must be aware. Endocrine causes including pheochromocytoma, thyrotoxicosis, hypothyroidism, Cushing's disease. Okay, and renal causes, these include renal artery stenosis. Okay, glomulopathies, acute nephritic syndrome, including even TTP-HUS also can produce secondary hypertension. So a number of causes which you have to try and revise. Okay, moving on to nephrology. ABG related questions, very high yield. Okay, if there are 3 areas where I know for sure they will ask you questions based on. One is ECG, one is ABG. Okay, and the third one comes in neurology, and that is about cortical functions. So these 3, they will definitely, if you have to read Harrison, read these 3 chapters, including at least ABG. ABG is not a very lengthy chapter. Okay, so, and they definitely ask questions based on it. So please be thorough with ABG. Regarding causes and compensation of different acid-base disorders, electrolytes, glomulopathies, complications of CKD, and hemodialysis. Now, glomulopathies has been discussed by Ranjana ma'am just a few days back, so I will not be going there. Okay, I'm sorry, these notes are still here. Right, so question asked last year was calculate the anion gap. Remember, don't take into account potassium for anion gap. We don't. Okay, potassium levels are affected by pH, and therefore we don't consider potassium, and in general the level of potassium in comparison to sodium is negligible. That's why for calculation of anion gap we only use sodium, and we subtract the sum of bicarbonate and chloride. Okay, so that will give you the anion gap. So here in this case, 145 minus 90 plus 20, that's 110. So obviously you get the answer as 35 rather. Okay, so the normal anion gap is up to 12, but by convention we take it to be somewhere. You can even extend it's rather from 8 to 12, so you can take it to be 10 also. Yeah, so 10, anytime it's about 10, clearly about 10, you should take it as abnormal. correct? So that's anion gap. So what raises anion gap will be organic acids. So organic acids which are anionic, and therefore the anion gap will be elevated, and that can occur either because of endogenous acids or exogenous acids. Endogenous acids would include lactic acid and keto acids, right? And exogenous acids could be a variety of toxic alcohols, including methanol, ethylene glycol, propylene glycol, isopropyl alcohol, toxic alcohols. Okay, as they are degraded, no, as the alcohol gets broken down into aldehyde, gets broken down into acid, and this acid raises the proton levels, and therefore the pH drops. Okay, so DKA, very good. So diabetic ketoacidosis. So ketoacidosis could again be diabetes related, it could be starvation related, it could be alcohol related. So alcoholic ketoacidosis is also there. And what you should watch out for is a potential question on euglycemic ketoacidosis. So euglycemic ketoacidosis is caused by which drug, which anti-diabetic drug? So the problem with that, in a patient with euglycemic ketoacidosis is your treatment will not be based on sugar or the blood glucose. Your treatment will be based on anion gap. Okay, till the anion gap normalizes, you need to continue giving them insulin infusion. So it's a tricky thing. You need to give them dextrose also. So you start with dextrose along with insulin in treatment of euglycemic ketoacidosis, which is a side effect of an anti-diabetic drug, very, very good drug, but that is why we don't give it in critical patients. So critically ill patients avoid this oral anti-diabetic agent because it can lead to euglycemic ketoacidosis. It's a potential question because it's not straightforward. No, patient's sugar may be given as 150 and the patient has presented with elevated levels of anion gap as well as beta hydroxybutyrate. So you do a serum beta hydroxybutyrate, it comes elevated. So you're stuck now. What do you do? So sugars are not high. If the patient has beta hydroxybutyrate levels being high, you need to control that. You need to give insulin, but you can't give insulin just like that when the sugars are only 150. You need to give it with dextrose. And till when do you give? You look at the anion gap. Till the anion gap normalizes or till the beta hydroxybutyrate levels normalize. Okay, so watch out for that question. Right, so Dr. Med said RTA are normal. Yes, RTA are normal anion gap metabolic acidosis, not metformin. Metformin leads to high anion gap metabolic acidosis. Metformin leads to something called type B L-lactic acidosis. Okay, lactic acidosis can be L-lactate and D-lactate. D-lactate comes from the intestines. L-lactate can again be type A, type B. Type A is because of hypoxia. Hypoxia meaning it could be because of shock, it could be because circulatory failure, it could be because of even carbon monoxide poisoning or even because of cyanide. So cyanide, if you're asked, cyanide produces type A L lactic acidosis, whereas metformin, drugs like metformin produce type B L lactic acidosis. Okay, SGLT2 inhibitors, very good. SGLT2 inhibitors, watch out for that. If you're treating a patient who's sick, who is critical with type 2 diabetes with SGLT2 inhibitors, it might precipitate something called, you might see their pH dropping, you might see anion gap increasing. If you do a beta hydroxybutyrate test, it will come positive. Patient may be having gone into euglycemic ketoacidosis. Right, so toxic alcohols, aspirin, remember aspirin needs to be treated with bicarbonate, right? Aspirin toxicity, you do something called forced alkaline diuresis for aspirin, that also can produce. Can paracetamol produce? Paracetamol, can it produce acidosis? Paracetamol, does it produce acidosis? Or rather, not lactic acidosis. Does it produce acidosis? Does it produce metabolic acidosis with the pH dropping? Paracetamol. Aspirin, it does. Aspirin definitely does. Aspirin also produces respiratory alkalosis, right? It stimulates the respiratory centers, produces respiratory alkalosis along with metabolic acidosis because it's an acidic compound, acetyl salicylic acid. That's aspirin. What about paracetamol? Acetaminophen. Does acetaminophen produce? If, okay, Dr. Med said yes. Why? But you guys know the answer would be something called pyroglutamic acid. Okay, no problem. Pyroglutamic acid is what is produced when paracetamol is metabolized in critically ill patients. So even a seemingly small dose of paracetamol given to critically ill patients can produce something called pyroglutamic acid, which again is acidic. Okay, so it's not just aspirin, even paracetamol can be associated with metabolic acidosis. Okay, so sorry about all this. Right. Patient recurrent vomiting, obviously you expect. The patient is losing HCl. So once they have lost HCl, definitely chloride levels will also go down, proton levels will also go down. So that means the patient will have metabolic alkalosis and they will have hypochloremia, and as a result they will also have hypokalemia. Hypokalemia is because when there is vomiting, there is a drop in intravascular volume. That will, so because there is reduced intravascular volume, there is going to be increased RAS activation, secondary. So secondary hyperaldosteronism will finally lead to hypokalemia, right? In general, even alkalosis itself can lead to hypokalemia because the potassium shifts inside the cells, but even because of RAS activation, the potassium levels will drop. So all these are expected. Respiratory alkalosis is not what you expect. Metabolic alkalosis should trigger a compensatory respiratory acidosis. So their breathing rate, the respiratory rate should come down. Okay. So that is why we fear metabolic alkalosis. Metabolic alkalosis. For example, in patients of COPD. So patient of COPD, patient presented with cor pulmonale. It was a chronic bronchitis patient. So you know chronic bronchitis patients are blue bloaters. They have developed cor pulmonale. Because of that, you gave them diuretics. You gave them furosemide. And once you give furosemide, you all know that furosemide can also lead to metabolic alkalosis, right? So the same pathway, it will produce diuresis, it will reduce intravascular volume, that will produce RAS activation, secondary hyperaldosteronism, and it will lead to metabolic alkalosis. As a result of the metabolic alkalosis, there is a compensatory respiratory acidosis. So the breathing slows down. So COPD patient who may already be in type 2 respiratory failure. So chronic bronchitis is the most common cause of type 2 respiratory failure because of hypoventilation. Okay, but if you gave them diuretic, you triggered metabolic alkalosis, and in compensation to that, they ended up developing respiratory acidosis that worsened their type 2 respiratory failure. You don't want further hypoventilation already when the CO2 levels are high. So these are certain concerns we have practically. Okay, so remember the causes of metabolic alkalosis, it's related to volume. So when the volume levels go down, it's called contraction alkalosis. So because of contraction of intravascular volume, there is secondary RAS activation, leads to development of alkalosis. Okay, so alkalosis as a result of RAS activation. RAS activation will also lead to reduced proton levels. Okay, so protons will get excreted along with potassium. Therefore, there will be hypokalemia, there will be metabolic alkalosis. Okay. So causes of acidosis, causes of high anion gap metabolic acidosis. Okay, one point I did not mention was about anion gap. So keep in mind when you are calculating, this is again a PYQ, that's why I am mentioning it. Anion gap, when you are calculating anion gap, keep in mind what is the albumin level, because albumins attach. Albumin is basically, it is also an anion, right? So that is why calcium attaches to it and protons attach to it, correct? So albumin is also anion, and that is why in the glomerulus it gets repelled by the glomerular filtration barrier, which is again negatively charged. So this is again an anion, right? So when the albumin levels are low, you need to correct for the hypoalbuminemia in calculating the anion gap. So you calculate the difference between the serum albumin from 4.5. So you take 4.5 as the cutoff minus the serum albumin of the patient. Okay, so minus the serum value of the patient. Yes, you should take the corrected value, Dr. Med. You should take the corrected value after calculating 4.5 minus serum albumin. This is what you need to apply to the anion gap. Okay, so remember, and this is to be rather multiplied by 2.5. I'm sorry, this is to be multiplied by 2.5. So 2.5 into this difference, 4.5 minus serum albumin. Okay. So while we are on this point, we also look at calcium. So when the albumin levels are low, you also correct for calcium. No, the difference is there you take 4 as the cutoff, 4 minus serum albumin, and there you multiply it by 0.8. Okay, so remember these two corrections that you need to apply when albumin levels are low. Anion gap needs to be corrected using this formula. Sorry, and calcium also needs to be corrected using this formula. Okay, corrected calcium levels. Right. So that is why when a person hyperventilates, what happens? Because of carbon dioxide washout, there is a respiratory alkalosis that sets in. In order to compensate for the respiratory alkalosis, the protons detach from albumin, and that allows calcium to come and bind to albumin, right? And that is why the person may end up developing carpopedal spasms. They may end up developing somewhat features similar to tetany, but full-blown tetany is unlikely in pure hyperventilation. Okay, so right, so what is the diagnosis in a sick COPD patient who has a pH of 7.3. 7.3 means the patient has acidosis, correct? Whenever the patient has normal pH is 7.35 to 7.45. Okay, 7.45. So whenever the pH drops below 7.35, it's acidosis. When it rises above 7.45, it's alkalosis. So if the direction of change of pH and PCO2 and bicarb is the same, then it is a metabolic process. If the direction of change of these two in comparison to pH is opposite, then it is a respiratory process. That's how you initially differentiate. Okay, if the pH has dropped and the carbon dioxide and bicarbonate have dropped. So remember, carbon dioxide and bicarbonate change will always be in the same direction, no matter what. As long as it's a single acid-base disorder, if it's a respiratory acidosis, for example, if the respiratory acidosis, PCO2 has been retained, bicarbonate will always rise. Okay, if the PCO2 got washed out, likewise, bicarbonate will also reduce. Okay, so the direction of change of bicarbonate and PCO2 is always the same. But the pH, if the pH change and the change of these two, the direction is the same, then you consider it to be a primary metabolic process. If it is different, like in this case, the pH has dropped, but PCO2 has risen. Normal PCO2 you will take it as 40. Normal bicarbonate you take it as 24. Correct? So the PCO2 has risen, the bicarbonate has risen, but the pH has dropped, which means it's a respiratory process. And obviously there is acidosis. So it's a respiratory acidosis. This much is clear, and therefore all four options have respiratory acidosis. Correct? Now, to check whether it's due to hyperventilation with adequate compensation or hypoventilation with adequate compensation and the various combinations. So, is there hyperventilation to begin with? No, because CO2, if there was hyperventilation, it will lead to CO2 washout, CO2 levels reducing. So, CO2 levels are high, that means definitely not these two. It's hypoventilation for sure. And after that, you need to check for bicarbonate levels as well as the pH. Okay, the first thing you look for is the pH to check if there is adequate compensation or without adequate compensation. If there is adequate compensation, the pH should have normalized. Okay, the pH should have normalized. But here the pH is 7.3. Okay, in any case, let us calculate whether the compensation from the bicarbonate is adequate or not. So we need to find out how much has the PCO2 risen by. So whenever there is a rise in PCO2 as a process or in the process of respiratory acidosis, for every 10 millimeter mercury rise in PCO2, it should be associated with a compensatory rise in bicarbonate by, if it is an acute process, if acute respiratory acidosis, the rise will only be 1 milliequivalent versus chronic it will be 4 milliequivalent. So as the process becomes more chronic, the kidneys become more efficient in saving bicarbonate and therefore the response improves. But then in acute respiratory acidosis it will be quite poor. So here the patient has developed respiratory acidosis with PCO2 jumping to 80. So that means if the cutoff is 40, 80 minus 40, it's risen by 40. So for a rise in PCO2 of 40, we should have had a rise in bicarbonate by 4. If it was as acute respiratory acidosis, it should have risen by 4 milliequivalents. If it was chronic, then it should have risen by 16. Correct? So in this case, it has risen by 4. Okay, so if this were to be depicting a sick COPD patient with pH of 7.3, then you have to consider that it might be an acute respiratory acidosis, in which case it becomes compensated. Okay, so 7.3 is quite close to 7.35. So in which case, because of this matching to what is given in the equation, our calculated the compensation of bicarbonate for this level of PCO2 is matching to the patient's scenario. Maybe the patient had acute respiratory acidosis. This becomes an adequate compensation. So hypoventilation, respiratory acidosis due to hypoventilation with adequate compensation. Clear? So in this case, we will have to take this into account. Okay, if it was chronic, if they had mentioned that the patient had chronic hypoventilation, then we could have taken as without adequate compensation. Okay. Yeah, so these kind of questions are very frequently asked. 7.3 becomes tricky since it's not normalized. We have to now decide whether the bicarbonate values are somewhat as expected or not. So in this case, because they are coming close to what was expected. Yeah, Dr. Vishma is asking, since it's chronic, yeah, so we don't know if they wouldn't have needed to mention sick, no? If they mentioned sick, it probably means there is an acute component. So in an acute component, Now if the pH is 7.3, yes, doesn't seem like it's compensated, but maybe it's trending towards it. What is more important is, are our values matching or not? So for a rise in bicarbonate by 40, in acute acidosis it should have risen by 4, which in this case it has. So the fact that they mentioned a 6 COPD patient tends to gain more importance from this point of view. Okay. So if they had mentioned only chronic, the patient is on a patient of chronic obstructive pulmonary disease who is not in exacerbation, not sick, then perhaps we could have taken it as not compensated. Okay, acute respiratory acidosis, this matches up. Purely the bicarbonate value, not the pH yet. Maybe the pH will eventually, but not yet. So these are important values that you should know. Okay, remember, whenever there is a metabolic process, there is going to be a change in bicarbonate and PCO2 in the same direction. Okay, whereas in respiratory, it's going to be in the opposite direction. And the compensation values, remember, whenever the other entity has to rise, whether it's PCO2 or bicarbonate, when it has to rise, it's more difficult. So that is why the compensation in metabolic alkalosis, where, I'm sorry, the arrows are wrong, where the values are rising, for each milliequivalent rise in bicarbonate, there's going to be an increase in PaCO2 by 0.275. Okay, 0.75. So the rise is always little tougher than the fall. In acidosis, the bicarbonate levels, when it drops, metabolic acidosis, when the bicarbonate levels drop, the expected drop in PaCO2 is 1.25. So for each 1 milliequivalent drop in bicarbonate levels, there will be an expected or anticipated compensation by 1.25 millimeters of mercury of PaCO2. Okay. So keep in mind that the rise is always more difficult. Likewise in respiratory also. So in respiratory also, I'm sorry, where did this go? In respiratory acidosis also, the PaCO2 is rising. So therefore, the compensatory rise in bicarbonate would be little more difficult for acute respiratory acidosis. Acute respiratory acidosis, the rise will only be 1 milliequivalent. Whereas in chronic, the kidneys improve and therefore 4 milliequivalent rise with 10 millimeters rise in PaCO2. Alkalosis, the drop is little better. So acute respiratory alkalosis, the drop is 2 milliequivalents for every 10 millimeters mercury drop in PaCO2. Whereas for chronic, again it is 4. Okay, so 1424 acidosis, alkalosis. Please memorize these. These will help you to determine exactly if there is compensation or not. Okay, so 1.25, 0.75. These are usually, they don't ask calculation based questions, but you have to be ready for them. Okay, this is a formula how to calculate osmolar gap. So just as a break, so you can remember the formula as 2 salty and sweet buns. Okay, so bun stands for blood urea nitrogen, and salty, that means 2 salty, that's 2 times sodium plus blood glucose. Okay, so that's sweet. So 2 salty and sweet buns is a formula for calculating plasma osmolarity. Remember, when you're calculating in millimole per liter, you need not apply any corrections. But if you're calculating in milligram per deciliter, you need to add, or you need to correct blood glucose divided by 18 and blood urea nitrogen divided by 2.8. Okay, these correction factors you need to apply when the values are in milligram per deciliter. Why this is important is, there are certain causes of high osmolar gap, high anion gap metabolic acidosis, which includes toxic alcohols. Toxic alcohols like ethylene glycol, methanol. Okay, methanol poisoning, they'll give you a history of there being vision issues, okay, vision problems along with the high anion gap, high osmolar gap metabolic acidosis. And in ethylene glycol, the patient would have consumed coolant or antifreeze and then developed calcium oxalate crystals in urine and then developed metabolic acidosis with high osmolar gap. So remember, high osmolar gap is given by what osmolarity you derive from the lab derived osmolarity minus calculated osmolarity. So what you got by calculation and what the lab gave you, the value the lab gave you, if they are different, if they are significantly different, generally the difference more than 15, then you consider that the patient has a high osmolar gap. So if this high osmolar gap is associated with high anion gap metabolic acidosis, you can think of toxic alcohols. Okay. Right, so again, an ABG question. ABG is showing pH 6.9, PO2 is 80, PCO2 is 55, bicarbonate is 10. Okay, and the repeat ABG, this was a November INI question. After 2 hours, the ABG the pH rather improved to 7.1, PO2 increased to 100, PCO2 ended up becoming 20, and bicarbonate remained 10. So how do you explain the second ABG? So if the question is how do you explain the second ABG, basic differences are the pH has improved along with the bicarbonate having improved. Okay, so in fact it's become less. Bicarbonate was quite high initially, now it's become less, and along with that the bicarbonate has not changed, the carbon dioxide has reduced. Okay, so carbon dioxide is reduced but the bicarbonate has not changed. So how do you explain the second ABG? Is it because of heparin excess? So what heparin does is it's an acidic compound. So whenever heparin is present in a particular solution, it will reduce the pH. So if the pH has increased, that means the person, or rather when adding heparin, the amount of heparin has definitely not increased because the pH has improved. If the pH has increased, that means there is no question of excess heparin. So if the pH had dropped further, you could have thought of excess heparin, but in this case it's not so. So remember, heparin is going to be acidic, it brings down the pH. Okay, since here the pH has increased, that's not the case. What about the PaO2? PaO2 is actually increased. Okay, so second ABG, PaO2 is increased. So this could also be due to do with the improvement of the patient also. So, but among the options, that option is not there, or in this question, the option is not there, and therefore you would have to go for excess air only. So excess air and less heparin would have to be the correct answer. So if you are talking about the second ABG, if the PaO2 has increased, it's because the air has increased, that has caused the oxygen levels to come up, and the pH has actually ended up increasing. Okay, so this is a more practical question, and this is how AIMS tends to ask related to practice, right? So expect these kind of questions also sometimes in between. But what you should know is heparin ends up reducing, it's an acidic compound, it reduces pH, and therefore you expect the pH to drop. The second pH should have dropped, but it's not, it's risen. That means it is got to be no question of excess heparin. Instead, the O2 levels have gone up. That means among these options, excess air with less heparin is the best one. Okay, this was what was asked in November. Okay, so which of these is not useful for management of hyperkalemia? This is again a very emergency based questions are very common in INI. So hyperkalemia management, remember everything is 10. So you give them 10% of 10 ml of 10% calcium gluconate over 10 minutes. Okay, this is not going to do anything to the potassium levels. It's only going to stabilize the cardiac membrane. And if you are seeing tall T waves, okay, tall T waves, let me show it as this is the QRS, and you see tall tented T waves, narrow based tall T waves in ECG, you have to think of hyperkalemia. If you see this, that means the cardiac membrane is unstable, it may throw an arrhythmia anytime. So that is why immediately you need to give them calcium gluconate. You need to give it slowly over 10 minutes, 10%, 10 ml. Okay. Likewise, insulin. Insulin is 10 units. You give 10 units. You look at the blood glucose levels. If the blood glucose levels are very high, you don't even need to give dextrose. Just give 10 units of insulin. Okay. If the patient has normal blood glucose, you don't want to give insulin for its glucose lowering property. You want to give insulin for its potassium lowering property. So that is why you need to add it to dextrose if in case the blood glucose levels are normal or on the lower side. So add it to dextrose, 50% or 25% dextrose, and give it. But the main thing you want is the insulin to act. So this is one of the faster acting medications for lowering potassium levels. But the fastest acting would have to be salbutamol. So albuterol is the other name for salbutamol. Salbutamol is a beta 2 agonist. So you give salbutamol via nebulization. You give it a higher dose, and that is also 10 milligrams. Okay, 10 to 20 milligrams, but at least 10 milligrams of salbutamol along with 10 units of insulin and calcium gluconate. So everything is 10. Please remember, this is acute management of hyperkalemia. For more sustained or maintenance of anti-hyperkalemic measures, you can give resins. Okay, potassium binding resins. You can also give patiromer. Patiromer is a newer drug, and you can also give the. Can you name another drug which you can give for treatment of hyperkalemia, for maintenance of hyperkalemia, apart from patiromer? one more drug. Okay, but that is for maintenance, not in acute hyperkalemia. Okay, magnesium sulfate has no role in treatment of hyperkalemia. Magnesium actually ends up, if magnesium levels are low, then it can lead to refractory hypokalemia. Refractory hypokalemia. Okay, but no role for magnesium in treatment of hyperkalemia. Okay, right. So hyperkalemia management is also important. Okay, this was another question that was asked in May of 2023. About which of the following statements is incorrect? Percutaneous biopsy not needed to diagnose FSGS. So clearly you do need it, right? So FSGS is focal segmental glomerular sclerosis. Unless you can visualize this under the microscope, you can't make a diagnosis. So FSGS definitely requires a biopsy. Minimal change may not require a biopsy if it's in a child. So if a child who has developed typical minimal change disease, all the components of nephrotic syndrome, then you can try giving a trial of steroids. Need not have to do a biopsy. And nowadays even membranous nephropathy need not be. I'm not saying this as this is a practical point. Okay, no books will give you this, but membranous nephropathy is more and more getting diagnosed based on a serology, an antibody test. I'll come to that also. But FSGS for sure we have no choice. You suspect FSGS in a patient who is an adult. Okay, an adult who has developed nephrotic syndrome. The most common cause is FSGS. So you do need to subject them to biopsy to make a diagnosis. Okay, post-renal biopsy, the patient should be observed for 24 hours. That sounds like a true statement. Passage of clots indicates hematoma formation. That's again quite logical. Systemic amyloidosis patients with renal dysfunction must always undergo renal biopsy. Okay, whenever you see among the options, if this kind of a multiple option filter kind of a question, whenever you come across always or never, whenever you see these kind of words in medicine, it's exceedingly difficult to prove or disprove. Okay, statements like always and never, those are always difficult to prove or disprove. So these will usually be distractors. So if you see always or never mentioned in any of these options, it should raise your eyebrows. You should neglect that option. Okay, so if they're asking for which is correct, then you neglect it. If they're asking for what is incorrect, you start suspecting that this is incorrect. Okay, so always and never, very, very difficult. So anyway, coming back to the statement itself, amyloidosis patient with renal dysfunction should undergo renal biopsy. So you need not have to, if it's a systemic amyloidosis, you need not have to take the biopsy from the kidneys. You can take it from the abdominal fat pad. You can even take a rectal biopsy. Okay, a renal biopsy would be slightly more invasive. So you can do it with lesser invasive methods. So it's not a compulsion, not a necessary investigation. So that is why this statement would be incorrect. This also should be incorrect, and therefore the answer is A and D. Okay. So it's again something more to do with practical. So this fact about monitoring the patient for 24 hours and the passage of clots could indicate hematoma formation. These are all more practical points that they have tried to ask in the past. Okay, so this is what I was talking about. Membranous nephropathy need not be diagnosed. Okay, this is not for your INI. Okay, the importance of this question is to only highlight which antibody is associated with it. But membranous nephropathy need not have to be diagnosed with biopsy. These days, practically I'm saying, you can make an indirect diagnosis. But for your INI exams, diagnosis requires biopsy. You want to reveal the spike and dome pattern, membranous nephropathy. Okay, but which is the antibody that is associated with membranous nephropathy? This was asked by Ranjana ma'am in her prepathon just a couple of days back also. So why I have shown this is, so this is the glomerulus trying to eat up the albumin. Membranous nephropathy is notorious for the amount of proteinuria it produces. So it produces a lot of proteinuria. It will end up producing such defects in the glomerular filtration barrier that a lot of proteins are lost. Even large proteins are lost. Large proteins like antithrombin 3. Antithrombin 3 is also lost. So because of large proteins like this being lost, antithrombin 3 is a natural anticoagulant. If that is lost, there is going to be a high risk for procoagulant state. So membranous nephropathy, remember, very high proteinuria, very high risk for procoagulation. So clotting risk, very high. Okay, and unfortunately what happens is this blood that is coming in through the afferent and efferent, going out through the efferent arterioles, this blood has just lost its antithrombin 3. So as it's getting drained through the renal veins, there itself the coagulation factors may be so high, not getting inhibited by any antithrombin 3 there itself the blood may clot. So that is why it ends up producing something called renal vein thrombosis. So renal vein thrombosis is a complication seen in membranous nephropathy in the veins itself, renal vein itself. And when the renal vein thrombosis develops, the patient will experience ipsilateral flank pain. They'll end up having hematuria. Their proteinuria will also worsen because finally back pressure, right? So renal vein, the pressure can be traced back all the way to the glomerulus, and the glomerular pressures are increased, more proteinuria. So proteinuria, someone who was a membranous nephropathy patient who was responding initially to immunosuppressives, they may end up becoming more resistant. Proteinuria increases, and unfortunately renal vein is in continuity with the inferior vena cava, so that thrombus may dislodge, may end up coming into the right side of the heart, lodging in the pulmonary arteries, and that may end up producing pulmonary embolism. So all these are complications possible in membranous nephropathy that you need to keep in mind. Okay, so very good. Saurabh has replied PLA2R, that is phospholipase A2 receptor. Antibodies to phospholipase A2 receptor, these are now being more and more used to try and make a diagnosis of membranous nephropathy. But of course, that is not a substitute, not yet. Not a substitute for renal biopsy. Please keep that in mind. Very good, Dharani also. The other antibody that is positive in membranous nephropathy patients is thrombospondin 7A. Antibodies to thrombospondin 7A receptors. Okay. So that is about membranous nephropathy. Also keep in mind Gitelman-Lidl and Bartter syndrome. Okay, so these are also very frequently asked. Remember, any patient who has metabolic alkalosis, you automatically think of these three as possible causes. Okay, the difference being Bartter's, very much like loop diuretic effects. The patient will not have hypertension. They'll be normotensives. Okay, normotensives, normal BP. And they will have metabolic alkalosis, and they will have hypercalciuria, calcium in urine. Okay, calcium in urine. Okay, whereas Gitelman's, they will also have normal BP, they'll have metabolic alkalosis, and they will have hypomagnesemia rather. Okay, magnesium levels are also low. Okay, this is very similar to thiazide diuretic effect, and Lidl syndrome is basically gain in function of the mineralocorticoid, or rather gain in function of the ENaC channels, and that is why the patients will end up having hypertension, that is a secondary hypertension, cause of secondary hypertension. Along with that, they will also have metabolic alkalosis. Okay, remember, aldosterone loves alkalosis. Okay, so anytime that the aldosterone levels are increased or the effects of aldosterone are increased, you expect metabolic alkalosis. Okay, so here of course the aldosterone levels will not be increased because it's a gain in function of the receptor. Aldosterone levels may be suppressed, but the effects of aldosterone are seen, and therefore they will have hypertension along with alkalosis and hypokalemia. Okay, so these are also frequently asked questions. Right. Okay, that's about nephrology. I'll try and increase my speed now. Again, emphasizing these are not the only points that you need to be studying. This is just a prepathon to try and help you figure out where are the focus areas from which questions have been arising so far. So Bartter's produces renal stones. Very good. Dr. Med has said that's because of the calciuria. So hypercalciuria, there is going to be renal stones also. Very good. Okay, so what is the opposite of Gitelman syndrome? So Gitelman syndrome, there is a problem with the sodium chloride, 2-chloride, right? So sodium chloride transporter. So what is the opposite? When there is a loss of function of this in the distal convoluted tubule, it will produce Gitelman syndrome. What is the manifestation when there is a gain in function of the channel, sodium chloride channel, co-transporter channel? Gordon syndrome. Very good. Gordon syndrome is a cause of secondary hypertension. So Gordon syndrome would be the opposite. So they will have metabolic acidosis, they will have hypertension. It's also called as pseudo hypoaldosteronism. Okay, type 2 pseudo hypoaldosteronism is Gordon syndrome, where there is opposite effects of what you see in Gitelman syndrome. Okay, so and ENaC gain in function is Lidl syndrome. Loss in function would be type 1 hypoaldosteronism. Okay, that much you can remember. You guys are reading well. Good, you're all answering well. Okay, moving on to neurology. Very, very important cortical functions, every time asked, and like you should anticipate that questions will be asked based on them. So be a little more thorough about this at least. Okay, so this one particular aspect you please study. See, ABG is a very high yield, it's a limited area, nothing has changed, there is no updates, there are no advances. Okay, ABG is a very high scoring area, so please do not neglect that. ECG, it's also high scoring. It's a little difficult to understand in the beginning, but with practice you will get better. So that is also high scoring. They will ask you ABG based questions, and that's why we covered that in the approach. But this is again yet another one. Cortical functions, very important. Okay, they will ask you, so try and read up about them. Brainstem stroke syndrome, as always, evergreen. Headaches, spinal cord, these are areas where they generally focus. Okay, neurology. So going on with it, patient with stroke unable to identify objects but can name or describe rather their color, texture and shape. Which of the following lobes is likely to be involved? So this was a tricky question. It was asked in November INI. So there might be a little bit of recall based error, because by description, if the person is able to identify, not able to name the object but can describe its features including color, texture and shape, this deficit would be called as anomia. So you know what it is. You can't name it, but you know what it is, what it's for and how its features are, but you can't name it. So that is anomia. And anomia unfortunately has very poor localizing value and lesions anywhere in the language circuit. So it's a very important language. So it's definitely on the left side. So if among these options something had mentioned left, that would have been great. So the others, if whichever was right, you could have ruled them out. Okay, but unfortunately, if it's anomia, then localizing it to a certain part of the dominant hemisphere is very difficult, because it's a very vast language network which traverses from frontal to the parietal through the temporal lobe also. So anomia localization is very difficult, but if you had to choose one, based on what Harrison has mentioned, it could be the temporal lobe. Okay, temporal lobe could be the lesion, dominant temporal lobe, left side temporal lobe for anomia. Whereas if instead the question had mentioned that the person is not even able to identify its color, texture or shape, not able to describe it at all, then it would be something called visual object agnosia. Visual object agnosia. So which means the person is not able to even describe it, nor able to name it. Okay, so visual object agnosia, they are not able to make out what it is. So if they're shown a toothbrush, they may think it's a pen, or basically they're not even able to say what it is. Okay, so not even able to identify or describe its features would be visual object agnosia. So which means the lesion is an occipital lobe. Okay, it's an occipital lobe lesion. So this is the question from recall base, but more important is what is the pattern, what are they trying to ask? They are trying to ask about cortical functions. Okay, and therefore you should be prepared, well versed with what are the different cortical deficits that can be expected. Yes, very good. Dr. Vishwanath said parietal again. If it is anomia, parietal again can be correct. Okay, in fact angular gyrus lesions in the dominant hemisphere. Okay, left angular gyrus lesion. What does it lead to? Angular gyrus lesion leads to something called dash, part of which is finger anomia, acalculia, dysgraphia or agraphia, and right left confusion. What are all these four? Right left confusion. When there's a dominant angular gyrus lesion, Gerstmann syndrome, very good, that is a PYQ, it's a previous year's question. So finger anomia, so that's the anomia component is not restricted to one particular place. It's very difficult to localize it. It's a very good indicator that the person has an aphasia, has a cortical problem, but exactly where, it's not a very good localizing feature. So that's why the question, it depends on what the question exactly was. If in case the person could not identify even the other features like color, texture and shape and couldn't name it, then it becomes visual object agnosia, which means the lesion is in the occipital. The occipital in the dominant left side, the dominant occipital lobe lesion will produce visual object agnosia. The non-dominant, the right or the non-dominant occipital lobe lesion will produce something called prosopagnosia. Okay, prosopagnosia. We'll come to that. Okay, right. So please beware of very important, and that's why I'll just highlight this. This is from my rapid revision video from the app, the Manipal Medis app. So please remember the cortical functions: frontal lobe, very important for executive functions, okay, to decide what is to be done, what not to be done. Those kind of complex decisions are taken in your frontal lobe. So if there's a lesion, so again frontal lobe can be subdivided into orbitofrontal cortex as well as dorsolateral cortex. When the orbitofrontal cortex is lost, there's a lesion there, then it leads to disinhibition. So the person behaves inappropriately, whether it's aggression, whether it's hypersexuality, all these inappropriate behaviors come if there is a lesion in the frontal lobe in the orbitofrontal cortex. It's called disinhibition syndrome. Dorsolateral frontal cortex, if there's a lesion, it leads to abulia, total lack of motivation, total loss of being proactive. So lack of motivation is abulia syndrome because of dorsolateral frontal lobe. Okay, primitive reflexes may get activated if there's a frontal lobe lesion. So the person may end up having the reappearance of glabellar tap, the reappearance of palmar grasp, plantar grasp, even sucking and rooting reflexes. All these may reappear. Okay, palmomental reflex. This is what you see in pediatrics, right? You need to read in pediatrics. Okay, so urinary incontinence, very important. So there's something called paracentral lobule. Okay, paracentral lobule is just beside, if you look at the cerebral hemispheres. So if you see the coronal view, okay, the cerebral hemispheres, the two hemispheres are like this, right? So the medial aspects of each of these hemispheres, they are supplied by ACA, the frontal lobe. ACA, okay, I'm sorry. ACA supplies the medial aspect of the frontal lobe, which contains this paracentral lobule. Okay, if this is the central sulcus, if this is the primary motor cortex, it has the motor homunculus. No, so the medial aspect will have, this is the coronal view, so I can't exactly show you, but I'll show you like this anyway. This is the lower limb, like, and then the proximal lower limb, and then further on there's the trunk, and laterally you will have the upper limb and the face and so on. Okay, so in the medial aspect, the representation, the upper motor neuron representation in the motor cortex, precentral gyrus, is for the lower limbs, right? And this paracentral lobule is the gyrus that is situated, the tissue that is situated in the medial aspect of the frontal lobe around the central sulcus. Okay, so that is why this paracentral lobule is important for lower limb control, the upper motor neuron representation. Also, it has, of course, it has the sensory cortex also, primary sensory cortex representing the lower limb, but it also has centers for urinary control rather. So center for urinary control, higher centers for urinary control are present in the paracentral lobule. So if there's a lesion in the paracentral lobule, it can lead to urinary incontinence also. This is what you see in patients of NPH, normal pressure hydrocephalus. They will have an increased pressure and therefore loss of tissue affecting this area, the paracentral lobule. That's why they end up developing gait apraxia. So gait apraxia is another feature of frontal lobe. Gait apraxia, don't think that apraxia is always parietal lobe. Gait apraxia is actually, it's also called Brun's ataxia or gait ataxia. So this is something that is seen, it's magnetic gait that is seen in patients of NPH along with urinary features. Okay, so frontal lobe, this is what you expect. Change in personality. So frontotemporal dementia, what will happen? Total change in personality. Doesn't behave what he was, how he used to. Okay, totally opposite of how he was. Now, frontal lobe, there's not much of difference between dominant and non-dominant, but temporal and parietal lobe, there are differences, which is why you need to know. This is where apraxia comes in. Apraxia, this is a PYQ. It is a feature of dominant parietal lobe lesion. Okay, so apraxia, when I say apraxia, I mean either ideational or ideomotor or idiomotor. Ideational or idiomotor. Okay, so the thing about idiomotor is, idiomotor apraxia, the person can put together certain bits of the steps that are involved. Okay, so for example, if the person with dominant parietal lobe lesion is given a toothbrush and asked to brush his teeth, he is not able to. He is not able to because the person has apraxia. Even though there is no upper motor or lower motor neuron lesion, pyramidal tract is intact, extrapyramidal tract is intact, cerebellum is intact, basal ganglia are intact, no sensory abnormalities, and he heard the instruction, he understood it also. But he's not able to do it because he's been asked to brush with a toothbrush. Instead, if the examiner instructs, pick up the toothbrush in your right hand, apply the toothpaste, bring it near your mouth, open your mouth, then start brushing, that means he'll do it. Okay, so step by step, if it is described, individual small steps, he is able to do it. He is able to function. But if he is asked to integrate all this, though he knows how to do it, he is not able to do it. That is called ideomotor apraxia. So the good thing about ideomotor apraxia is it doesn't it doesn't it doesn't cause disabilities to the patient. So the person can still be independent. On instruction, the person is not able to do. But if he really wants to brush his teeth, he'll pick up the brush and he'll do it everything by himself. But he's not able to do it on command. So that is the problem with ideomotor apraxia. Ideational apraxia is just the idea itself is just not going to come. Even with the smallest of step, just take the toothbrush in your hand means he's not able to do it. Okay, so even a single step cannot be followed is ideational. That thought of the planning of the particular act itself is not there. That is ideational apraxia. Ideomotor is at least the person can be independent, they can do it themselves, but on command, when they have to add 2 plus 2 plus 2 plus 2, they're not able to do it. But if they're asked to do 2 and then 2 and then 2, they're able to do it. Okay, so apraxia, dominant parietal lobe lesion. This is a PYQ. The two types of apraxias that are not dominant parietal lobe, they are non-dominant parietal lobe, are constructional apraxia and dressing apraxia. Okay, so potential PYQs, if they ask which of the following is not because of a dominant parietal lobe lesion, the dressing apraxia and constructional apraxia would be the answers. Otherwise, all other buccofacial apraxia, limb kinetic apraxia, ideational apraxia, ideomotor apraxia, all these are dominant lobe. Okay, dysphasias may be seen. Parietal lobe is where the arcuate fasciculus is, so conduction aphasias may be seen because of parietal lobe lesions. Dominant. Okay, dominant is decided by language function. Where is the language? Contralateral inferior quadrant nopia. This is common to both dominant and non-dominant. Acalculia, and these four we discussed are Gerstmann syndrome. Gerstmann syndrome, dominant angular gyrus lesion, which is in the parietal lobe. Okay, non-parietal or non-dominant lobe lesions will lead to spatial disorientation. Okay, this typically affects Alzheimer's disease patients. Okay, they lose their way. They're not sure where they've come. If they've ventured outside the house, they're not sure where they are. They lose track. Okay, so spatial disorientation, constructional apraxia, as I said. Constructional apraxia is used as a screening test in detection of hepatic encephalopathy. Okay, contralateral inferior quadrantopia is the same, and contralateral hemineglect. Okay, hemineglect is yet another PYQ. So remember, when there is, in terms of attention, the dominant hemisphere, the left side hemisphere is only going to control the attention towards the right side of the body, whereas the right sided hemisphere, the right parietal lobe, will have attention towards both sides of the body. Okay, so that means for the left side of the body, only the right parietal lobe is having attention, whereas for the right side, both parietal lobes are having attention. If there is a lesion that involves the right parietal lobe, the non-dominant parietal lobe, the left half of the body would be neglected, and that is called hemineglect. Okay, right-sided non-dominant lobe parietal lobe lesion will lead to left hemineglect. Okay, you don't get a right hemineglect. It's very unusual and uncommon. So in INI, it's impossible. So they'll only ask you typical manifestations. Okay, atypical or very rare manifestations of a. If they have to frame a case scenario, they'll frame the more typical manifestations of it. They can't give you atypical case scenarios. They'll give you a typical case scenario. So right hemineglect, almost impossible. Left hemineglect is what you get because of a non-dominant parietal lobe lesion. Okay. So what you should also keep in mind is prosopagnosia, which I'll tell you again. Prosopagnosia is the inability to recognize familiar faces. So inability to recognize familiar faces is prosopagnosia, which occurs due to a non-dominant occipital lobe lesion. So there again, occipital lobe also a little bit of difference is there between dominant and non-dominant. Non-dominant occipital lobe lesion leads to prosopagnosia, inability to recognize familiar faces. Coming to temporal lobe, okay, you can get complex hallucinations because of temporal lobe involvement, the limbic system involvement, memory impairment again, seizures, mesial temporal sclerosis, right? So mesial temporal sclerosis, there is going to be hippocampal atrophy. Okay, seizures would be there, very complicated seizures. That means focal seizures with dyscognitive features. Okay, focal seizures with dyscognitive features. Again, superior quadrantopia. So if it's a temporal lobe, it's superior quadrantopia contralaterally, and if it's parietal lobe, it's inferior quadrantopia. Wernicke's aphasia, because the Wernicke's area lies in the superior temporal gyrus, left-sided superior temporal gyrus. Okay, non-dominant temporal lobe. That is because of lesions in this, there can be poor non-verbal memory, loss of music skills, complex hallucinations. Okay, one more word, aprosody. Okay, what is aprosody? Aprosody is when there is a lack of emotional intonation when one is speaking. Okay, instead of me saying, "Hi, how are you?" So if I say like this, it's very monotonous. There's no emotion to it. So instead I say, "Hi, how are you?" There's an emotion to it. So that kind of intonation that comes into speech, that is called prosody. the prosody is decided by the non-dominant hemisphere. The fluent speech is coming out because of the dominant hemisphere. The emotional intonation within that speech is coming from the non-dominant hemisphere. So if there is a non-dominant hemisphere frontal lobe lesion, that corresponds to Broca's area. So Broca's area is in the the inferior frontal gyrus of the dominant hemisphere. Whereas if there is a inferior frontal gyrus lesion in the non-dominant hemisphere, you get aprosody. Okay, potential MCQ, potential INI question. Okay, so occipital lobe lesions can lead to simultagnosia, prosopagnosia, optic ataxia, oculomotor apraxia. So actually the combination, so simultagnosia of course is in the it's in the occipitotemporal, rather it's in the occipitotemporal region. Okay, let me not put it as occipital lobe, I'll put it as occipitotemporal cortex. Okay, so lesions here can produce these four, and a combination of these is known as Balint syndrome. I'm sorry, not temporal, parietal. Apologies, parietal, occipitoparietal. So lesion in this region can end up producing Balint syndrome. Balint syndrome is a combination of simultagnosia. Simultagnosia is where you cannot get the entire picture. For example, in the ECG, if I showed you the ECG and you're not able to see the PQRS together, you're only able to see only one QRS. You're not able to see the next QRS. If I ask you to calculate rate, you need to see the two QRSs together, no? But you're not able to see it. You're only able to see only QRS, one QRS. So that is simultagnosia, not able to get the entire picture. Only a part of the picture you can understand or you can receive. Okay, that is asimultagnosia, is when you're not able to picture the entire, you're not able to grasp the entire picture simultaneously. Asimultagnosia. Prosopagnosia is inability to recognize familiar faces. Usually it's in the non-dominant occipital lobe. Optic ataxia is when you're not able to judge the distance from, if you are seeing something, if I'm seeing my laptop in front of me, I'm not able to judge the distance between me and my laptop. So that is optic ataxia. Oculomotor apraxia is I want to move my eyelid, or rather eyeball. If I want to move my eyes to a particular direction, but I'm not able to. So that is called oculomotor apraxia. Very good. Himanshu said missing the forest for a tree. So you're shown a forest, you see only one tree. That is asimultagnosia. Very good. Missing forest for trees. Okay, if you remember, if you know about the story of, just divulging for briefly, okay, if you know about the story of Arjuna, so when Dronacharya was giving archery training to Pandavas, so everyone thought unfairly Dronacharya was favoring Arjuna, but he had a point. Dronacharya had a point because Arjuna was clearly superior to all the others. So what he did was he kept a wooden bird on a tree branch, and he asked Pandavas one by one to come and take their shot at it, the archery, to bow and arrow. And when each of the Pandavas came, he would ask them, as they were about to release their arrow, he would ask them, what do you see? What are you seeing? They would describe, I'm seeing the bird, I'm seeing the tree, the branch, the sky behind, and all that. Okay, all of them, none of them were able to tell in a focused way. When Arjuna's turn came, what did he say? He can see only one thing. He can see only the eye of the bird, right? And when he released his arrow, it went straight and hit the bird, whereas all the others missed. So this is somewhat like asimultagnosia. Of course, it's a very good thing for Arjuna that he was able to hit the target accurately, and that is a testament to his techniques. But asimultagnosia is where you're shown everything, but you're able to see only one thing. Okay, so that example was only to sort of highlight what is asimultagnosia. I'm not saying Arjuna had asimultagnosia. He had his own superior talents. Okay, right. So these are important. One more area I feel questions will come are on aphasia. Aphasia based questions are anyway being asked, but what you should try and look at is where you can falter. Okay, so you know that Broca's aphasia, it's the fluency is lost. So these are the three main things that you need to look for: fluency, comprehension, and repetition, to try and make a diagnosis of the speech disorder that the patient has. Okay, so if the fluency is lost, it's Broca's area. Okay, because the output is coming from Broca's area. So if the speech is non-fluent, the Broca's area is likely to be affected, especially when repetition is also lost. So in Broca's aphasia, fluency is lost, repetition is lost. In Wernicke's aphasia, comprehension is lost and repetition is lost. Fluency is maintained. So the previous year's question was, fluent aphasia is seen in, and the answer is Wernicke's aphasia. fluency is maintained, but the output is totally gibberish. Okay, patient with sensory aphasia or Wernicke's aphasia, the lesion in the dominant superior temporal gyrus, they are not able to comprehend what they are being told. Okay, they are not able to make sense. They can hear, but they are not able to make sense out of those words. And likewise, when they are asked to speak, they'll end up speaking in it's called neologism. So it will be filled with new words, meaningless sounds. So neologisms as well as jargon speech. Okay, so jargon speech and neologisms are what are used by patients with fluent aphasia due to Wernicke's area lesion. Okay, so loss of comprehension with fluent speech but filled with the meaningless words with loss of repetition is Wernicke's aphasia. So these are things I think you're all familiar with, right? So there should be not much of an issue trying to make out what is Broca's aphasia and what is Wernicke's aphasia. Don't think too much about reading and writing. Reading and writing is lost in many of these aphasias. Naming is lost almost universally in everything. That is why localizing naming, when there's anomia, localizing becomes very, very difficult. It's difficult. Okay. What I feel can be tricky is conduction aphasia. Now, conduction aphasia, remember, comprehension is intact and speech output is also intact. So, fluency of speech is intact, comprehension is intact, repetition is lost. So, person is able to speak when he wants to, person is able to understand what you said, but you ask them to repeat something, they're not able to. Okay, so if you're asking them to read out a newspaper, they're not able to. But when they want to read their newspaper by themselves, they're understanding whatever is being written. So, they're able to read well, they're understanding it also, but asked to repeat, they can't. Okay, so please remember, in conduction aphasia, repetition is lost, comprehension, fluency is maintained. Isolation aphasia, I feel, is a tricky one where they can pose a question based on. So, in isolation aphasia, repetition is intact. Okay, they are able to repeat, but they are not understanding. There is no comprehension, and even the speech output, the fluency is lost. Okay, so speech output lost, fluency is lost, and comprehension is lost, but repetition is intact. So, what will this lead to? Repeating of words. So, you ask them to repeat something, they are repeating it. But are you understanding what I am saying? No, they are not. So, this is known as echolalia. So, they may give you a scenario where a person has developed a stroke and person is only repeating whatever is being told to him, but is not understanding, the comprehension is lost and the speech is non-fluent. So, what kind of aphasia is it? It is isolation aphasia. Okay, so these are possible questions based on aphasia. Okay, so please revise aphasia and cortical functions. Okay, and just a word on brainstem stroke syndromes. So I'll do this fast. I'm sorry, not here. Brainstem stroke syndromes. You all know very well about brainstem stroke syndromes. So let's take it a little fast if you don't mind. The midbrain lesions. So what are the midbrains? First of all, so to begin with, if there is a brainstem stroke, there is going to be contralateral hemiplegia. So there is going to be crossed manifestations basically. So crossed manifestations need not be hemiplegia. Like in lateral medullary syndrome, there is no hemiplegia. So crossed manifestations are important. If there are crossed manifestations, certain manifestations on ipsilateral, certain manifestations contralateral, then you localize it to the brainstem. Now, where in the brainstem will be decided by which cranial nerves are involved. So, in the case of Weber's, or rather in the case of midbrain, you have Weber syndrome where there is third nerve palsy with contralateral hemiplegia. You have Benedict syndrome. Okay, so Ben is an addict. What addict? Is an alcohol addict. So, because Ben is an addict, he is drinking alcohol, his eyes are becoming red. Eyes are red. Okay, Ben, who is an addict, drinking alcohol, eyes are red. And when he stops drinking, he develops withdrawal tremors. Okay, remember Ben is a Korean also. So Ben from Korea, he is an alcohol addict. He consumed alcohol, his eyes became red. He stopped drinking, he started developing withdrawal tremors. Okay, so this is Benedict syndrome. Okay, so Benedict syndrome, the lesion is in the red nucleus. Therefore, the eye is lost. Along with that, they have rubral tremors. Okay, so rubral tremors are seen even in, and chorea is also seen. So it's a Korean man. Ben is a Korean man. So chorea is another feature of Benedict syndrome. Okay, and that's a midbrain lesion. Third nerve. The moment you say so, third and fourth nerves are in the midbrain. Okay, fifth, sixth, seventh, eighth are in the pons. Everything below is in the medulla. Okay, so if the third nerve is getting involved, fourth nerve syndromes are very rare, so you don't expect fourth nerve syndromes. Okay, third nerve syndrome is what may be asked, mostly will be asked. So if the patient has contralateral hemiplegia along with third nerve, it's Weber syndrome. If the patient has Benedict syndrome, the lesion in the red nucleus along with the third nerve. So the patient will have ipsilateral third nerve palsy along with tremors and chorea. Okay. And if the patient is having North-Nagel syndrome, it's a more dorsal syndrome. It will be associated with third nerve and contralateral ataxia. Okay, it's a more dorsal midbrain syndrome. The most dorsal midbrain syndrome is Parinod, but even North-Nagel is a dorsally, the lesion will be situated dorsally. Claude syndrome is a combination of Benedict and North-Nagel. Okay, it's a more extensive lesion. Even the red nucleus is involved. Superior cerebellar peduncle is also involved. Okay, the ataxia in North-Nagel syndrome is because of involvement of the lesion in the superior cerebellar peduncle. Okay. Yeah, I'm sorry if I'm going a little fast, but I'll do my best to try and still make it understandable. Okay, so Claude syndrome is a combination of Benedict and of North-Nagel. Okay, Parinod syndrome, you can remember Parinod syndrome using this mnemonic. I know Parinod spelling is PA, okay, so but for the sake of the mnemonic I have kept it as PE. So but please remember it's Parinod syndrome. But Parinod syndrome you can remember as the mnemonic Perinod. P stands for pineal gland tumor. Usually Parinod syndrome doesn't occur because of a stroke, it occurs because of pineal gland tumor. Okay, so P is for pineal gland tumor, E is for eyelid retraction, it's called Collier's sign. R is reflex dissociation, that means the light and accommodation reflexes, they dissociate. It resembles an Argyll-Robertson pupil, so accommodation reflex is present but no pupillary reflex or no light reflex. Infraduction, that means sunset signs, the person will keep looking down, that's I. N is nystagmus. What kind of nystagmus? Can you guys answer in the chat box? What kind of nystagmus do you see in Parinod syndrome? Abducens, so it's not a true abducens palsy. Because of the increased convergence, it seems as though there is abducens palsy, that's why it's called pseudo-abducens. And upgaze palsy is again as a result of infraduction, so the person remains looking down, Collier's sign, so they're not able to look up. And dorsal, it's a dorsal midbrain syndrome, so D is for dorsal midbrain syndrome. Okay, so remember, whenever something involves the vertical gaze means the problem lies with the midbrain problems will give rise to vertical gaze problems. Okay, when the problem is in the horizontal gaze, the problem lies in the pons. Okay, so pons is when it's a horizontal gaze problem. Okay, so nystagmus, anybody? I'll wait for that answer. Right, so that's about the midbrain syndromes. What about pontine syndromes? We have a few pontine syndromes. These include, okay, I've not mentioned, okay, I've mentioned here. So the Raymond syndrome is just a sixth nerve palsy with contralateral hemiplegia. And remember in Millard-Gubler, everybody knows this mnemonic, Millard-Gubler, right? So Millard has 7 letters, Gubler has 6 letters. So that's why the lesion in Millard-Gubler is 6th and 7th nerve palsy. So in 6th and 7th nerve palsy, the problem here is the lesion lies in the fascicle of the 6th nerve. So therefore, the person will have problems with abduction towards the same side. So if the patient has a right-sided Miller-Gubler, their abduction to the right side is impaired, but the gaze is still intact. So the opposite eye, the medial rectus can still contract. So they don't have a gaze palsy, they only have an ipsilateral abduction palsy. Whereas if the patient has a Foville syndrome, the lesion lies at the level of the 6th nerve nucleus. So 6th nerve nucleus lesion will lead to total gaze palsy. Neither will the ipsilateral lateral rectus contract, nor will the contralateral medial rectus. Okay, so total gaze palsy, ipsilateral gaze palsy will be there if there is a Foville syndrome because of a 6th nerve nucleus lesion along with the 7th nerve lesion. Okay, 7th nerve, remember, wraps around the 6th nerve to produce a facial colliculus. Right, and sometimes you can get a lateral pontine syndrome also. It's called Mary-Foch syndrome. So in Mary-Foch syndrome, there will be Horner's. So remember, when there is eyelid drooping, no, if a patient has a brainstem stroke and has developed eyelid drooping, it could be because of Weber syndrome, because the third nerve is gone, because third nerve is also important for third nerve lesion also produces ptosis, or it could be because of Horner's syndrome. Horner's syndrome can occur in lateral medullary syndrome, which everybody knows, but it can also occur in lateral pontine syndromes. Lateral pontine syndrome occurs due to occlusion of the anterior inferior cerebellar artery, leads to Mary-Foch syndrome. Okay, or lateral pontine syndrome, where they'll have 7th nerve palsy also, 8th nerve palsy also, but along with that they'll also have Horner syndrome ipsilaterally. Okay, nobody answered for the nystagmus. It's convergence retraction nystagmus. Okay, convergence retraction nystagmus. That's the kind of nystagmus you see in patients of Paranoid syndrome. Okay, and finally coming to medullary syndromes, medial medullary, everybody knows there will be ipsilateral 12th nerve, hypoglossal nerve palsy. So when you ask them to protrude the tongue, if there's a right-sided hypoglossal nerve palsy, the tongue will also deviate to the right. Okay, so tongue deviates to the same side of the lesion. So along with that, contralateral hemiplegia. Medial medullary syndrome, there is going to be hemiplegia. Lateral medullary syndrome, no hemiplegia. Instead, they'll have all the other cranial nerves getting involved. Starting from the 5th cranial nerve, so there is the crossed manifestations in lateral medullary syndrome is there is loss of pain and temperature from ipsilateral face with loss of pain and temperature from contralateral body. Okay, that is the crossed manifestation in patients of lateral medullary syndrome. Please keep that in mind. Along with that, they'll also have Horner syndrome. They'll have loss of taste. There'll be a lesion in the nucleus tractus solitarius. There'll be a lesion in the nucleus ambiguous. Okay, rarely 7th nerve may also get involved, but otherwise it's 5th inferior vestibular nucleus there'll be a lesion. So 5th, 8th, sometimes 7th, 5th, 8th, along with that 9th and 10th, and it will spare the 12th, of course. Okay, so remember 5th nerve, it's the spinal nucleus. It comes quite far below the level of the I remember I told you 5th nerve is pons, but the spinal nucleus of 5th nerve, it has 4 nuclei. Trigeminal nerve has 4 nuclei. The 5th nerve spinal nucleus comes down all the way to cervical spinal cord also, up to C2, C3 also it can come down. So that is why when there is a lesion in the lateral aspect of the medulla, you can have a 5th nerve manifestation. Okay, right. So these are the brainstem syndromes. Just revising briefly. Okay, remember the arteries also. The artery occlusion for posterior inferior cerebellar artery syndrome is not pica. It's actually vertebral artery. And in case of again medial medullary syndrome also, the artery involved are the branches of vertebral artery. Okay, and basilar artery occlusion is for pontine. Okay, and posterior cerebral arteries for the midbrain syndromes. Okay, sorry, midbrain syndromes. Midbrain syndrome is the posterior cerebral arteries. Okay, right. So that is about brainstem syndromes. The management aspect, you all know what are the indications for thrombolysis, what are the contraindications. Please make sure the blood pressure is less than 185 by 110. That is the cutoff for if you want to plan for thrombolysis. The indication for thrombolysis is the patient should have had symptom onset less than 4.5 hours ago, and the patient should not have cerebral edema exceeding 1/3 of the cerebral hemisphere. Okay, on a CT scan, initial CT scan you do. So when the patient arrived, you put the patient, subject the patient to a plain CT. You knew that the deficits are there, and therefore you did a plain CT that showed edema which was less than 1/3 of a hemisphere, and patient had come within 4.5 hours of the onset of symptoms. Therefore, the patient can go undergo thrombolysis or fibrinolysis. And even after that, you can subject them to a CT angiography. You did a plain CT. Patient was in the window period. You thrombolyzed. Along with that, do a CT angiography. In the CT angiography, if you see that there is an occlusion of a large vessel, like for example, occlusion of the internal carotid artery, main internal carotid artery, or the basilar artery, or a vertebral artery, along with middle cerebral artery. So the proximal middle cerebral artery, internal carotid artery, basilar artery, if these are occluded, then you can subject them for mechanical thrombectomy. Okay, so mechanical thrombectomy within 24 hours you can still do. The thrombolysis is 4.5 hours. Mechanical thrombectomy is 24 hours. So if a patient arrives outside of the window period, you can still directly offer them mechanical thrombectomy. Okay, so moving on. I hope you guys are all with me. I have not heard back from you guys since that nystagmus question. So based on the brainstem stroke syndromes, the patient has loss of pain and temperature from right half of the face and left half of the body. So there's your crossed manifestation. There is no mention of hemiplegia. Patient also has drooping of eyelid, miosis, and loss of sweating, probably on the ipsilateral side of the face. Horner syndrome. Where's the site of the lesion? Since it's right side, okay, right side loss of pain and temperature, that means the lesion must be in the right side of the medulla. Okay. So right, we still have headaches. Okay, so this is a slide to try and summarize headaches. Remember, primary headaches are very frequently asked. It's not coming fully, is it? Okay, primary headaches are very frequently asked. Treatment aspects of primary headaches are very important. So remember, cluster headache treatment acutely is through the nose, whether it is nasal sumatriptan or if it is inhaled oxygen, or even the treatment can be with zolmitriptan, nasal zolmitriptan also. So, or subcutaneous sumatriptan, or through oxygen. And oxygen flow rate should be at least 10 liters per minute, 10 to 15 liters per minute. That is a PYQ. Okay, so 10 to 15 liters of oxygen per minute. This is for acute treatment. Prophylaxis, you can use steroids also. Prednisolone can be given, or you can use anti-migraine drugs like verapamil, like topiramate, even galcanezumab. So galcanezumab is another option for treatment of cluster headaches. So these are trigeminal autonomic cephalalgias which I am summarizing. Okay, treatment for paroxysmal hemicrania is indomethacin, exquisitely responsive to indomethacin. And for short lasting unilateral neuralgiform headache with autonomic dysfunction or conjunctival suffusion and injection and tearing, that means SUNA and SUNCT, the treatment for these would be lamotrigine. Lamotrigine works very well. So you can use duration of treatment to try and arrive at the diagnosis. Usually the cluster headaches episodes, of course there will be periodicity, it will be more common in men, it will be more common among alcohol will be a trigger, but the duration of attack will be in hours. Whereas in paroxysmal hemicrania, the duration of attacks will be in minutes. So 20 to 30 minutes of headache per day, unilateral periorbital headache, and lasting for 20 to 30 minutes. That is paroxysmal hemicrania. Give them indomethacin, it settles. SUNA and SUNCT, very frequent attacks, very short lasting attacks, lasting only for a few minutes, sometimes seconds to sometimes minutes, but multiple times in a day. Lamotrigine works very well. Okay, so these are certain important aspects of headache, regarding headache. Okay, so apart from that, also migraine related aspects, migraine related questions are very common, so please revise about migraine treatment. Okay, including GIPANTs, the new GIPANTs and DITANs, all these are important aspects which need to be revised before your INI exams. Okay, so I'm leaving that to you. Dementia, very important. Dementia, we'll quickly revise in this table the different dementias. Alzheimer's disease, the characteristic early manifestation is episodic memory loss. Okay, additional features none. Alzheimer's disease is mainly linked to only the brain. Although there is there is a little bit of speculation that type 3A diabetes is what is linked to Alzheimer's disease, but that is not universally accepted. Okay, type 3A diabetes. You know, type 3C diabetes is pancreas, right? So type 3A diabetes is said to be because of Alzheimer's, but it's not universally accepted. Nonetheless, histologically, you see intracellular or intraneuronal neurofibrillary tangles and extraneuronal amyloid plaques. And these amyloid plaques are A beta 42, right? And Hirona bodies are additional histological findings. Radiologically, you'll see medial temporal lobe atrophy, entorhinal cortex being affected first. Okay, and genetics wise, what is important is trisomy 21, presenilin 1 and presenilin 2 on their respective genes, chromosome number 14, chromosome number 1. And the trisomy 21 is associated with an increase in levels of the protein APS. Okay, so and that is why they can end up developing early Alzheimer's. Trisomy 21 Down syndrome patients can develop early Alzheimer's. ApoE4 has an increased risk for random or rather sporadic Alzheimer's disease. Okay, so ApoE4 mutations on chromosome 19 can lead to sporadic Alzheimer's disease. Treatment: memantine, rivastigmine, donepezil, galcanezumab, galantamine. But remember the monoclonal antibodies which are used in Alzheimer's disease. Can anybody name the monoclonal antibodies approved for treatment of Alzheimer's disease? Okay. Likewise, frontotemporal dementia, remember there will be executive function loss. That means they'll behave very awkwardly. Inappropriate behavior will be the feature in frontotemporal dementia. Association with motor neuron disease, especially ALS. So ALS is associated with behavioral variant frontotemporal dementia. Remember, frontotemporal dementia can be behavioral variant or aphasic variant. The temporal lobe getting atrophied more is aphasic variant. Frontal lobe getting atrophied more is behavioral variant. Okay, so any answers for the monoclonal antibody associated or used in treatment of Alzheimer's disease? Okay, so right, so histologically in frontotemporal dementia you may see PIC bodies. These are again intraneuronal inclusion bodies called lecanemab. Okay, yes, very good. So lecanemab is the monoclonal antibody most recently approved for use in Alzheimer's disease. Okay, and apart from that, any other antibodies you can use, monoclonal antibodies? Okay, the answer is aducanumab. Okay, aducanumab is the other antibody. Okay, coil bodies, you can also see inclusions that are rich in tau protein and FUS, that is fused in sarcoma, and TDP43. TDP43, aducanumab, very good. Himanshu, absolutely correct. And tau, these account for the most common, most of the cases of frontotemporal dementia. So not much in radiology, it's frontal and temporal atrophy. Remember the genes C9, ORF72 as well as MAPT. Okay, these are the genes mutations responsible for frontotemporal dementia. Treatment, there is no specific treatment for frontotemporal dementias or any of the other dementias for that matter. Okay. PSP, progressive supranuclear palsy. Remember, I told you midbrain, when there's a lesion, there's a vertical gaze issue. So, like in Parinaud syndrome, where there is an upgaze palsy and there's sustained down gaze. Likewise, in progressive supranuclear palsy, also there's midbrain atrophy, but there's sustained upgaze and there is a down gaze palsy. Okay, so down gaze palsy with frequent postural instability leading to drops or falls rather. So, frequent falls with an upgaze palsy. This is what is seen, or rather in down gaze palsy, this is what is seen in patients of progressive supranuclear palsy. Okay, so down gaze palsy, and this is again a tauopathy. Hummingbird sign. So hummingbird sign in MRI is because in the sagittal section the midbrain has atrophied. That's why it appears as if it's a hummingbird. It looks like a hummingbird. That is on sagittal section. On the cross sections you can see morning glory. It appears as if morning glory or Mickey Mouse sign. That's what they describe as, because of the atrophy of the midbrain. Again, no specific treatment. Okay, electrooculogram finding of PSP is square wave jerks. These are additional points. Okay, and Lewy body dementia, it's a subcortical dementia. Lewy body dementia is a alpha synucleopathy, and it's characterized by Parkinson-like features. So is PSP. PSP also has Parkinson-like features, but there's a lot of postural instability in both. Postural instability is both, but autonomic dysfunction is much more in patients of Lewy body dementia. And REM sleep behavioral disorder, this is again another very important feature along with Parkinson's in patients of Lewy body dementia. So Lewy bodies are what you see in patients of Lewy body dementia on histology. Okay, prion disease, rapidly progressive, young age of onset, very aggressive course, characterized by dementia along with myoclonus. And on EEG you will see something known as polyspike with wave. Okay, polyspike and wave. So SSPE, you know that SSPE is a post-measles, or rather it's a chronic measles infection, right? So subacute sclerosing panencephalitis. So it's a complication of chronic measles infection. So likewise, you can remember the EEG finding. There are polyspikes and slow waves periodic emissions. Okay, so spike and slow wave periodic emissions. This is what you see both in SSPE and in prion disease. Okay, myoclonus is what you get clinically. Spongiform degeneration on histology, or rather on gross examination. Okay, right. So this is about dementia. What I'll do is I'll just give you guys a break for 2 minutes and then we'll resume. I'll wrap up soon though. Okay, just a break for 2 minutes. You guys can catch your breath. I'll be back. Hi. So, okay, what we'll do is I'll finish up the neurology part in a few more slides, and we'll continue the remaining chapters in another part subsequently. Okay, so I don't want to overburden you guys also. So quickly we'll wrap up whatever's left in neurology, a few slides, and then we'll wrap up today's session. Right, so spinal cord disorders. This is also very important from your INI point of view. So in spinal cord disorders, can you guess these? I hope you're able to see the contrast. Okay, so I'll read it out also. If there's a lesion affecting the anterior horn cell in the spinal cord, if there's a lesion affecting the anterior horn cell, the corticospinal tract, but it's sparing the dorsal column, lateral spinothalamic tract, and urinary bladder function, what would the diagnosis be? So remember, if both LMN and UMN lesions are there and everything else is spared, you have to think of mainly a disorder that's affecting only the motor neurons, which means it's a motor neuron disease, right? So a motor neuron disease that's affecting the spinal cord, it could be a part of ALS, or it could be a primary lateral sclerosis also. So generally primary lateral sclerosis affects the LMN also, so more likely to be ALS. So when there is combined LMN and UMN, you think of ALS, okay? Especially when there is a UMN manifestation in the upper limb and an LMN manifestation in the lower limb, then the diagnosis almost always is ALS, amyotrophic lateral sclerosis. Very good, Dr. Vishwanath. Thanks for staying with me. Okay, so thanks, Himanshu. Very good. Correct. So that is the first one. So number one is ALS. Next, if there's a lesion that's affecting the corticospinal tract, sparing the anterior horn cell, along with that, the dorsal column is lost. So the myelinated tracts are lost. If the myelinated tracts are lost, and it spared the anterior horn cell, it spared the lateral spinothalamic tract and the urinary bladder. So that means it's a lesion that's affecting the myelinated fibers, which is probably you guys can try and guess. Okay, next lesion, if there's a lesion that spared the anterior horn cell, affected the corticospinal tract, spared the posterior column, affected the lateral spinothalamic tract, okay, and urinary bladder is also lost, or urinary bladder function is also lost. Okay, I'll have to apologize for a correction here. The anterior horn cell also will be lost. Okay, in this anterior horn cell will also be lost. So what pattern you can make out is all the anterior structures are lost and the posterior structure is spared. Dorsal column is spared. Anterior structures lost, posterior structures spared. What is the difference between the anterior structures and the posterior structures in the spinal cord? Mainly blood supply. Okay, the anterior spinal artery supplies the anterior 2/3 of the spinal cord to the single anterior spinal artery. The two posterior spinal arteries supply the posterior 1/3 of the spinal cord. That's why if there's an occlusion, it will affect the anterior 2/3 of the spinal cord mainly, because it's a single ASA that is reinforced at every level by intercostal arteries. But there is, of course, the artery of Adam-Kiewicz. If that is occluded, that means it is going to lead to a watershed infarct in the spinal cord, the anterior aspect of the spinal cord, leading to this kind of manifestation, where the only thing that is spared is the structure that is supplied by the posterior spinal arteries, and that is anterior spinal artery infarct. Okay, so if the anterior horn cell is also lost and all the structures are lost, all the structures in the spinal cord are uniformly lost. Okay, bladder is lost. Usually the bladder would be the first to be lost in this particular. So the person is not able to pass void urine, there is bladder distension, there is urinary retention. Along with that, the person develops paraparesis, person cannot feel anything, person develops a level of sensory loss above which the person can't perceive any sensations. So this is something that is typical in transverse myelitis. So this would be transverse myelitis. Okay, transverse myelitis, acute transverse myelitis, it's a total section. So in patients, so the common doubt that arises is between transverse myelitis due to NMO and transverse myelitis due to multiple sclerosis. The difference is in NMO, it will be transverse myelitis that affects more than 3 or more segments of the spinal cord in continuity. So transverse myelitis, that is longitudinally extensive. Longitudinally extensive transverse myelitis is a feature of NMO, whereas in multiple sclerosis it will be patchy. Okay, it will not affect it will neither affect continuous length of spinal cord, several segments in continuity, nor will it be completely transverse. Okay, it may spare a few tracts. Of course, it affects mainly the myelinated tracts, but it may still spare a few tracts even in a particular cross section. So that is transverse myelitis, where everything is supposed to be lost. Okay, what if there's a spinal cord lesion where the anterior horn cells and the corticospinal tract is intact, dorsal column is lost, bladder is lost, but lateral spinothalamic tract is intact? This is what you get in tabes dorsalis. Tabes dorsalis, that is tertiary syphilis, neurosyphilis. Tabes dorsalis, as the name suggests, dorsalis. Dorsal column is the only thing that's lost, along with bladder sensations. The person will have a rather neurogenic bladder. Okay, and then what if only the corticospinal tract is lost, but all the other tracts are intact in the spinal cord? This is primary lateral sclerosis. This is also a motor neuron disease. ALS is also a motor neuron disease. Amyotrophic lateral sclerosis, amyotrophy, that means there is muscle wasting. Amyotrophic lateral sclerosis, this is a type of motor neuron disease which has both upper and lower motor neuron manifestations, whereas primary lateral sclerosis, lateral because it's the lateral column in the spinal cord, it is the it's the corticospinal tract. If you look at in the spinal cord, the corticospinal tracts are laterally located. So amyotrophic lateral sclerosis, that is amyotrophy plus lateral sclerosis. Primary lateral sclerosis is only sclerosis of the corticospinal tract within the spinal cord, that is another type of MND. Okay, and finally, if there is anterior horn cell that is lost, along with loss of lateral spinothalamic tract and urinary bladder, but sparing of the dorsal column. So this is called dissociative anesthesia, where there is sparing of the posterior column sensations, but loss of lateral spinothalamic tract. This is what is seen in syringomyelia. So syringomyelia, or an intramedullary compressive lesion, can produce this kind of a picture, where there is dissociative sensory loss. Okay, so this was just to try and make it a little unique regarding how to study for spinal cord. Otherwise, please remember spinal cord disorders. Syringomyelia is very important. It's been asked. Dissociative sensory loss, suspended anesthesia, that is also important. It's like cape-like distribution. Okay, so only a certain segment, a certain few of the dermatomes, there will be loss of pain and temperature, but they will still have intact fine touch. They'll have intact proprioception. Okay, and along with that, they'll have atrophy because element type of lesion, and they'll have bladder. Okay, bladder involvement, because the bladder fibers pass very close to the central canal, and if there is a syringomyelia, it will affect the surrounding fibers, the fibers surrounding the central canal first. So that's why bladder involvement is quite early in syringomyelia. Okay, otherwise, one thing that we did not say was this kind of a posterolateral. So this kind of a posterolateral syndrome is what you get, myelin, right? So this is what you get in patients of B12 deficiencies. Subacute combined degeneration of the spinal cord, vitamin B12 deficiency, you can get this kind of loss of posterior column as well as the corticospinal tract, myelinated fibers. Differentials for this would be copper deficiency, vitamin E deficiency. You can also see a similar picture in HIV vasculopathy. So HIV could also produce vasculopathy resembling this. Okay, so this is about spinal cord disorders, a few aspects regarding it. So remember, if there is anterior spinal artery infarct, the patient will complain of sudden onset back pain along with acute paraparesis, and this paraparesis will spare the posterior columns. Okay, sparing the posterior columns, right? And this should be it. Okay, for discussing of spinal cord. Okay, one question that was asked in last INI was, last INI was regarding if a patient with Alzheimer's disease is not able to or not willing to take oral medications, what are the alternatives for him? Rivastigmine can be given as a transdermal patch, and therefore that is the answer. So if similar question applies for Parkinson's disease, remember rotigotine and apomorphine along with newer preparations of levodopa are also available parentally. Okay, parental preparations are available. But otherwise, for Alzheimer's disease, among these options, rivastigmine is the one which can be given transdermally. This was a question that was asked. Okay, so I will wrap up in just a couple of slides. This can you identify those guys who are live? Can you identify what is the deficit here? an aged brain is not the husband, aged husband is not able to identify the aged wife. So he's asking tum kaun ho, and a familiar face when it's not getting recognized, what is it? Next, the person, the aged brain himself cannot identify, the husband himself cannot identify himself, he can't remember, he's asking main kaun ho. So that means the person has a sort of memory loss. And finally, if the wife is stunned at how the husband is behaving, total behavior change, what is it? Okay, so inability to recognize familiar faces is prosopagnosia, can occur in strokes, especially in the non-dominant occipital lobe. Okay, episodic memory loss is what characterizes Alzheimer's disease, where they are very forgetful, and memory loss is a prominent feature. Memory loss is not a very prominent feature of frontotemporal dementia. Instead, it occurs, rather the memory loss is a feature of Alzheimer's disease, especially episodic, whereas behavioral variant frontotemporal dementia is where the behaviors change, and that's because it affects the frontal lobe, either the orbitofrontal cortex or the dorsolateral frontal lobe. Okay, so this is about Pick's disease, which is frontotemporal dementia. Frontotemporal dementia was earlier known as Pick's disease, now they're not synonymous. The better answer is frontotemporal dementia. Okay, just something to help you remember. Okay, primary progressive MS, this was a question 2 or 3 years ago, I think, and the question was primary progressive MS, what is the drug of choice? It still remains ocrelizumab. Okay, so ocrelizumab is the drug of choice for primary progressive multiple sclerosis. Okay, multiple sclerosis. All the others can still be given, and glatiramer acetate is the safest anti-multiple sclerosis drug, but in terms of primary progressive MS, choose ocrelizumab. Primary progressive MS tends to affect the spinal cord more often. Okay, I think what we'll do is, with this we'll close today's session on general medicine prepathon. It turned out to be quite long, but your enthusiasm also sort of forced me to discuss perhaps more than maybe what I should have been. But that's how medicine is, especially to someone like me who has a lot of passion for medicine. It gets you going. So, and then it becomes difficult to stop, but I can understand that there are real problems with having to sit and watch through for a very long time. So what we'll do is we'll give it a break, a long break. We'll continue the rest of the medicine prepathon in another part subsequently. Okay, and we'll let you know about what dates we'll do that on. But otherwise, I thank all of the people who tuned into the session today, and those who are still live, I especially thank them for taking out time and still sticking to the session. Hope it was beneficial. Hope you find it to be useful. And if you have any doubts, you can always get back to us. You please do try out the Manipal Medes app and do make use of those videos and those resources. We have MCQs. We have a lot of we have notes which are especially designed. So please make use of all these, and please do get back to us in terms of feedback. And if you have any doubts, please do continue to add them in the comment section. We'll get back to you. Okay, if those of you who are wondering about the PDF sessions regarding PDF notes about today's session, you will be getting it on the app, and we'll intimate it to you how soon it will be available. Okay, and finally thanking Manipal Medes and the entire team and all my other colleagues for their support. Okay, so, and for those of you who will watch this in rewind later in 1.25 or 1.5x, because frankly that is what I would also have done. So to all of you, thank you very much. So with that, we'll close today's session. Thank you once again.